Welcome to a deep dive into endotracheal and tracheostomy sectioning. We're going behind the scenes of a procedure that is super important in respiratory care.
It's kind of fascinating how suctioning wasn't always something we did, routinely, I mean.
Yeah.
It's only after we started understanding more about keeping the airways clear to prevent things like pneumonia.
Makes sense.
It became a cornerstone of respiratory care.
Like, almost like plumbing. You got to keep the pipes clean, right?
That's a really good analogy. We're talking about different tools and techniques. And today we're focusing on open suctioning, the classic manual way, and closed suctioning, which is a newer technique
Yeah.
with its own advantages.
Okay, so first things first. Why do we even need suctioning?
Well, think about a patient who, let's say, can't cough up mucus on their own. Like maybe they're under anesthesia or they've got a breathing tube,
Okay, yeah.
or maybe they have a condition that makes it hard to clear their airway. It's like their airway becomes like blocked.
Yeah, that makes sense.
And suctioning is kind of like that plunger that comes in and boom, clears the blockage.
Yeah.
It could be a lifesaver in a lot of cases.
So literally a lifesaver.
Yeah.
Okay, so before we get into the nitty-gritty of open and closed sectioning, let's back up a sec and talk about tracheostomies.
Right. So a tracheostomy is basically a surgical procedure that creates an opening.
Yeah.
Right.
Okay.
In the neck.
Mm-hmm.
Goes right into the trachea.
The windpipe.
Yeah, the windpipe. And it's like creating a detour, you know,
Yeah.
when the normal route for air is blocked or there's a problem.
Like a road closure.
Exactly.
And for folks with a tracheostomy, suctioning is even more important then.
Oh, absolutely. Because with the tracheostomy, you're bypassing those natural filters and things in the upper airway.
Okay, so those secretions can build up.
They can build up more easily, in the trachea. And suction doing that regularly helps keep that tracheostomy tube clear
Yeah.
so the patient can breathe okay
Yeah.
and be safe.
Okay, so we've established that suctioning is vital, especially for people with tracheostomies. Let's set the scene for our listener. Imagine you're a healthcare provider and you're about to perform suctioning on a patient. What's on your mind? Like, what's the setup?
Well, the first thing is always patient safety and keeping things sterile. Like, think of it as setting up a mini operating room.
Okay.
We got to protect ourselves. We got to protect the patient from any infection.
Right.
So gloves and masks, those are a must-have, of course.
Of course.
And then you've got the tools.
Yeah. Like, what are the tools of the trade here?
Well, you have your suction unit, of course, that provides the suction, that negative pressure,
Right.
to pull the secretions out.
Okay.
And then there's different kinds of suction catheters. And those are the tubes that we're actually putting into the airway.
Okay. So, like, different pipes need different size plungers.
Exactly. We choose the size really carefully based on how old the patient is, how big they are.
So it's not one size fits all, clearly.
No. Especially when you're talking about babies,
Mm-hmm.
We're dealing with tiny little airways.
Yeah.
It's all about doing it safely and effectively.
So there's a chart for that, right? Like a guide.
There is. It helps match the catheter to the patient's anatomy.
Oh, that makes sense.
And, of course, you got monitoring equipment,
Yeah.
things like a pulse oximeter that tracks the oxygen levels,
Okay.
and an EtCO2 adapter to monitor their carbon dioxide throughout the procedure.
So it's like having a dashboard to make sure everything is okay.
Exactly. You want to make sure everything is going smoothly.
Oh, we've got our sterile field, we've got our suction equipment, and we've got our monitoring tools. Let's actually talk about the procedure. Let's start with open sectioning.
All right, so with open suctioning, it's a step-by-step process. And communication is, like, really key. Even if the patient is, not fully conscious,
Right.
you want to explain what you're doing. Just a touch and a few words can make a big difference.
It's still about acknowledging the patient.
Yeah.
Right.
Yes, absolutely. Then it's about positioning. You ideally want them sitting up a bit, to open up the airway.
Yeah.
But you have to adjust depending on their condition.
And then you're prepping for the suctioning.
Right. Pre-oxygenation. That's super important. You give them extra oxygen before disconnecting them from the ventilator or the bag valve mask.
Right, because you're interrupting their airflow.
Right. It's like giving them a deep breath before a quick dive underwater,
Yeah.
Then you've got your pulse oximetry on to watch those oxygen levels. Then, of course, picking the right catheter size, sterile technique the whole way through.
So every step, like minimizing the risk of infection.
Absolutely. Now, you set the suction pressure.
Yeah.
That's the force that pulls the gunk out, right?
Okay, yeah.
Again, the size of the patient really matters. Imagine the airway like a delicate pipe.
Okay.
Too much pressure, and it's like using a pressure washer on a tiny pipe.
Could cause damage.
Right, it can cause damage.
Yeah.
So we adjust that pressure carefully based on the patient's age, their size.
So you're making sure you're clearing it out but not causing any harm.
Right. That's the goal.
Okay, so we've got the pressure set, sterile technique. We're ready to go into the airway.
Yep. Breathing tube is in place. Then we disconnect from the ventilator or bag valve mask.
Oh.
Now, to help that catheter slide in smoothly, we lubricate it with sterile saline, just reducing friction.
So it's like smooth and steady wins the race.
That's a great way to put it.
Yeah.
Now, with the catheter lubed up, you gently advance it into the breathing tube, and you just go nice and slow until you feel resistance or the patient starts coughing.
Okay, and I want to highlight something here. We're not suctioning yet.
Exactly.
Why is that?
Because if you're suctioning while you're putting the catheter in, you could hurt those delicate tissues in there. You only suction on the way out.
Got it. Okay, so the catheter's in place. We're ready to suction. What happens next?
So you put your finger over a vent hole on the catheter, and that creates that negative pressure. And as you pull the catheter out, you twist it a little to clear a wider area. But there's a time limit, the 10-second rule.
Oh, wow. So you've got a timer going.
Yeah, you got to be quick.
Right.
Because suctioning for too long can cause hypoxia, which is a drop in the blood oxygen levels.
Okay.
It's like holding your breath for too long.
Right.
We don't want to do that to the patient. So short bursts of suctioning is the key.
10 seconds to clear the airway and then back to oxygen. What happens after those 10 seconds?
Right away, reconnect the ventilator or the bag valve mask. Let the patient recover their oxygen levels. And you rinse the catheter really well with sterile saline, just to get rid of any leftover secretions. And then, if you need to, you can repeat. But you always wait at least a minute between tries
Okay.
to let those oxygen levels bounce back up.
So it's like this delicate balance between clearing the airway and making sure they have enough oxygen. It's pretty amazing how much goes into each step.
It really is. And this is just open suctioning. Closed suctioning offers a totally different approach.
Well, we're definitely ready to dive into that next.
Closed suctioning. It's kind of like, moving from a manual plunger to a high-tech drain snake.
Okay, I like that analogy. But before we get into that, we've talked a lot about the technical stuff. But what about the patient? What's it like for them? Can't be that comfortable, can it?
No, you're right. It can be pretty uncomfortable. Some folks describe it as like a tickling or pressure in their throat.
Yeah.
Others, they might feel like gagging or even short of breath for a bit.
Yeah, that makes sense. So how do you guys, as healthcare providers, how do you make it as easy as possible for the patient?
It all starts with communication, really. Like I said before, explaining what's happening.
Yeah.
Even if they aren't fully awake, it can really help calm them down.
Right.
Being gentle and working fast also helps.
Yeah, makes sense. Like you're treating the person, not just the procedure.
Yeah, exactly. And sometimes we could even use medication to help the patient relax during the suctioning.
Oh, that makes sense. Especially for kids or babies.
Yeah, exactly. Especially then.
Yeah.
And getting parents or caregivers involved can help a lot too. A familiar voice, a comforting presence, it can make a huge difference.
Yeah. Okay, so let's get back to the technical side. What are the big advantages of this closed suctioning compared to the open way, I mean?
Well, the biggie with closed suctioning is that it really cuts down on the risk of infection
Mm-hmm.
because the catheter, it stays inside this protective sleeve the whole time.
Okay.
It's like a shield for the airway.
So an extra layer of protection.
Exactly. Plus, it can actually be more comfy for the patient because you're not stopping their breathing during the procedure.
Oh, so you don't have to disconnect them from the ventilator.
Yep.
That's a big difference for comfort and oxygen levels?
Exactly. Now, a lot of the steps are pretty similar to open suctioning. Positioning, pre-oxygenation, keeping things sterile, that's all the same.
Okay, so the basics are still there.
Right. But instead of disconnecting, you attach this closed suction catheter to a special port
Okay.
on the ventilator or the bag valve mask.
So you've got a built-in access point.
You got it.
Yeah.
And then you slide the catheter through that protective sleeve, just like with open suctioning.
Okay.
And you're feeling for that resistance or cough to know you're in the right spot. Then you pull it back a tiny bit and use this thumb valve to start the suction.
So controlled suction.
Right. And then after, those 10 seconds or less, you lock the thumb valve so that nothing goes back into the airway.
Oh, that's smart.
And then you rinse the catheter using a special port built right in. It's all designed to keep everything sterile.
Like a self-cleaning system. Pretty cool.
It is pretty neat, actually. And after rinsing, you're ready to go again if you need to, always remembering to give the patient time to recover their oxygen.
Okay, so closed suctioning is more controlled, maybe even safer, especially for patients who are already on a ventilator or bag valve mask.
You got it. Less risk of infection, continuous ventilation, and it can be more comfortable.
Now, we've talked about both open and closed methods. Are there any other things to watch out for? Complications or things like that, no matter which method you're using?
Yeah, we've talked about hypoxia, right? Low oxygen levels from suctioning for too long.
And sticking to that 10-second rule is key.
Right, exactly. But there's other things too. You could hurt the airway, cause some bleeding, or even infection. Even though we're doing our best to keep things clean.
So it's like walking a tightrope. You want to clear the airway, but you don't want to cause other problems.
You got it. It's all about balance. That's why it takes someone with a lot of experience and skill to do this right.
So the healthcare provider needs to be really good at this.
Absolutely. They got to have a steady hand, good judgment, and they got to really understand how the respiratory system works.
Yeah. It sounds like it's more than just a procedure. It's like an art.
Yeah, it really is. And for folks with tracheostomies, there are also things to think about long-term, not just during the procedure.
Okay. So living with a tracheostomy, what are the challenges?
One of the biggest is infection. The tracheostomy tube, it bypasses all those natural defenses in the nose and mouth.
Right, so it's easier for germs to get into the lungs.
Exactly. So keeping the area around the tracheostomy super clean is really, really important.
Okay, yeah.
You got to watch out for any signs of infection, redness, swelling, that kind of thing. And another thing is tracheal stenosis.
Stenosis, what's that?
Basically, it's when the trachea starts to narrow.
Oh, wow.
Yeah, sometimes scar tissue can form around the tracheostomy site.
So the opening starts to close up.
Yeah, that can happen.
Yeah.
And then it gets hard to breathe.
So the trachea needs regular care to prevent that.
Absolutely. Regular checkups with a doctor or nurse are really important to make sure the tracheostomy is doing okay.
Okay. It sounds like having a tracheostomy is not just a one-time thing. It's a long-term commitment.
Yeah, you're right. It is. It takes a lot of work and attention. Now, sometimes the tracheostomy is just temporary,
Yeah.
Eventually, the person can breathe on their own again.
So there's hope that things can go back to normal.
Definitely. When that happens, we take the tube out and the opening heals up. But even then, there might be some scarring or changes that need watching.
It's like the trachea has to learn how to work again on its own.
Yeah, that's a good way to put it.
Yeah.
So the bottom line is that managing a tracheostomy, it's a journey. It takes a team effort.
Between the patient, their family, and the healthcare team.
Yep. Working together to get the best outcome for the patient.
Okay. So we've covered suctioning, tracheostomies, and all the things that go with them. It's amazing how much goes into keeping those airways open and making sure people can breathe.
Yeah, it's pretty incredible, huh? And that actually brings us to another important technique, tracheal stoma ventilation.
Okay, so now we're talking about actually delivering breaths, not just clearing the airway.
Exactly. With tracheal stoma ventilation, you're putting breaths right into the tracheostomy tube, bypassing the mouth and nose altogether.
So the air goes directly into the lungs.
Yep. And it's really important for people who can't breathe well on their own or need extra help getting enough oxygen.
So there are special considerations for this too, right?
Oh, absolutely. The type of tracheostomy tube, the patient's condition, the settings on the ventilator, it's very specialized.
So the healthcare providers need special training.
Yeah, for sure. And one of the big things is making sure there's a good seal around the tube.
Kind of like a tight connection on a garden hose.
Exactly. If there are any leaks, the patient might not get enough air. And just like with suctioning, you got to keep a close eye on their vital signs,
Okay.
like their oxygen levels and how fast they're breathing.
Make sure their lungs are filling up and they're getting enough oxygen.
Right. And you got to keep the airway moist too. When the air bypasses the nose and mouth, it doesn't get humidified naturally.
Like using a humidifier at home when it's dry.
Exactly. So we use these devices called HMEs, heat and moisture exchangers, to add moisture to the air.
So you're kind of recreating what the body does naturally.
That's the idea. And
Yeah.
just like with any other procedure, we document everything carefully.
Okay. So keeping track of all the settings, how the patient's doing, any changes, that kind of thing.
Exactly. It helps everyone stay on the same page and make sure the patient gets the best care possible.
Okay. So we've talked about suctioning, tracheostomies, and this tracheal stoma ventilation. It's been a really interesting look at how important respiratory care is.
It is, isn't it? Maintaining a clear airway is critical. And for people who can't breathe on their own, these procedures, they can be lifesavers.
Yeah.
But they take skill, knowledge, and compassion.
It's not just about the science, it's about caring for the person too.
You said it. Now, before we move on to our final thoughts, I think it's important to talk about some potential complications, things that can go wrong even when everyone's doing their best.
Yeah, because there are always risks, right?
Right. We already mentioned hypoxia, low oxygen levels. That can happen if you suction for too long.
And that 10-second rule is super important.
Yeah. But you could also hurt the airway, cause bleeding, even infection.
So it's this balance between helping them breathe and making sure you don't do any harm.
Exactly. And that's where experience and skill really matter. The person doing this needs to know what they're doing.
Steady hands, good judgment.
Yep. And for people who have tracheostomies, there are also things to think about long term.
Like what? What kind of challenges do they face?
Well, we talked about infection. It's a big one.
Right, because the tracheostomy tube kind of creates a shortcut for germs to get in.
Exactly. And then there's tracheal stenosis, that narrowing of the trachea.
Oh, right, where the opening starts to close up.
Yeah, it can be a serious problem. And it's why follow-up care is so important.
They need to be monitored to make sure everything is healing properly.
Exactly. Now, for some people, the tracheostomy is temporary,
Okay.
and they can eventually breathe on their own again.
So it's not always a permanent thing.
Right. And when that happens, we remove the tube and let the opening heal. But even then, there might be some scarring or changes that need to be watched.
So it takes time for everything to go back to normal.
It does. Managing a tracheostomy, it's a long process, and it takes teamwork. The patient, their family, and the healthcare team all working together.
It really emphasizes that healthcare is about the whole person, not just the procedure.
Absolutely.
Yeah.
Now, there have been some incredible advances in medical technology that are really making a difference for people with breathing problems.
Yeah, it seems like there are new developments all the time.
There are. For example, we have portable ventilators now
Wow.
that let people with tracheostomies get out and about, live more normal lives.
That's a huge change.
It is. And there are new tracheostomy tubes that are more comfortable and less likely to cause problems.
It's amazing to think about how far we've come.
It really is.
Yeah.
I'm excited to see what the future holds.
Me too. So, as we wrap up this deep dive, what's the one thing you want our listeners to remember?
I think the biggest takeaway is this. Keeping the airways clear is absolutely essential for life. And for people who can't breathe on their own, these procedures, suctioning, tracheostomies, ventilation, they can be lifesavers. But they require specialized knowledge, skill, and compassion from the healthcare team.
It's both a science and an art.
Well said. And if anyone wants to learn more about respiratory care, we'll put some links in the show notes.
Great. The more we know, the better we can advocate for ourselves and our loved ones.
Couldn't agree more. So are you ready to take a peek into the future of respiratory care?
Absolutely. Let's do it. We've talked about how tracheostomies, and suctioning, how they can be lifesavers. But what if we could go beyond that? Like, what if we could actually, regrow damaged lung tissue?
Wow, yeah.
That would be incredible.
That's a really fascinating area of research. I mean, the field of regenerative medicine is just, like, exploding right now. And the potential, to actually regrow lung tissue, that's really exciting.
It's like rebuilding a house, Instead of just patching up holes, we could create brand new, healthy lung tissue.
Exactly. That's the ultimate goal, right? And, I mean, there's a lot of challenges, but scientists are making some real progress in understanding, how to help the body repair itself.
So like helping the body heal itself.
Exactly. And stem cells, they're showing a lot of promise. They have this amazing ability to turn into different types of cells.
Including lung cells.
Yeah, including lung cells.
Ah.
So it's like giving the lungs new building blocks.
Yeah,
right?
they're the raw materials.
Exactly. And researchers are trying to figure out the best ways to get those stem cells into the lungs.
All right.
Like injecting them directly or building like these little scaffolds. That can support new tissue growth.
It sounds like science fiction.
It does, doesn't it?
Yeah.
But it's actually happening. And another area that's really interesting is looking at genetics. How genes play a role in lung disease,
So if we can figure out the genetic code, maybe we can create like personalized treatments.
Exactly, yeah.
Yeah.
Treatments that actually target the root cause of the problem. And with all the advances in gene editing, those kinds of therapies are getting closer and closer to reality.
It's incredible. Imagine a future where we can not only treat these conditions, but actually prevent them in the first place.
That's the dream. And, as we keep learning more about the respiratory system, I'm sure we'll see even more amazing breakthroughs in the years to come.
It's pretty inspiring. So for our listeners, if you're as excited about the future of medicine as we are, stay curious. The quest to conquer lung disease, it's not over yet.
That's for sure. Well, I think that about wraps up our deep dive into suctioning, tracheostomies, and the future of respiratory care.
It's been a fascinating journey. We hope you learned a lot and maybe even feel inspired to explore the world of medicine a little more yourself.
Absolutely. And until next time, keep those airways clear, those minds curious, and those imaginations going.
All right, get ready, because today we're diving deep into the world of the female reproductive system.
Oh, it's a fascinating one.
It really is. It's so complex and just incredible and...
It's really amazing how everything works together.
Right. Our guide for this journey is going to be this super interesting audio lecture all about anatomy and physiology.
Perfect.
And, I've always been so curious about how this whole system works,
Right.
from the basic anatomy stuff
Mhm.
to, how the hormones work together for the menstrual cycle.
Yeah.
And then pregnancy.
Pregnancy is wild.
Oh, it's mind-blowing. So let's just jump right in and start with kind of the, anatomy 101.
Okay.
Like just the basics.
For basics.
The vagina, which, is also called the birth canal.
Right.
It's kind of the gateway to this whole system.
It is.
It connects the cervix, which is the lower part of the uterus, to the outside world.
Mm-hmm.
It's about 10 centimeters long, but
It's tiny.
it is. But get this. The lining is super thin and stretchy.
That's crucial.
Why is that?
Well, think about it. For childbirth,
Yeah,
it has to stretch to let a baby through,
that's true.
and it also has to accommodate, sexual intercourse.
Right.
And the discharge of, menstrual fluids.
Right.
So it really has to be able to stretch.
It's pretty amazing when you think about it, like
This is amazing.
how much it changes and
Yeah, full.
adapts. Okay, so let's move on to the ovaries.
Okay.
The egg producers,
Yes,
these little almond-shaped organs,
Hmm.
they're in the pelvic region.
Yep.
And they're the ones that release, that precious egg every month
A month, yep.
or ova.
Mm-hmm.
And once an egg is released, it goes on this journey through the fallopian tubes.
Yeah, it's a trip.
It is. It's like a highway to the uterus.
Like a little highway.
I know. And I was reading that these tubes have these tiny little hair-like structures.
Oh, yeah, the cilia.
Yeah, the cilia.
It's so cool.
They are. I never even knew they existed.
They create a current. It's almost like they're these little cheerleaders,
Well.
moving the egg along.
Oh, that's so cute.
I know. A microscopic pep rally.
I love it. Okay, so the egg travels down this little highway, and it ends up where?
The uterus,
In the uterus.
of course.
Of course. This amazing, powerful, muscular chamber
Yeah.
where the magic happens.
The magic of pregnancy.
Yes. It houses and nourishes the growing fetus,
Mm-hmm.
and then it also contracts during labor
Powerfully.
to deliver the baby.
It's really quite something.
It's a lot of work.
It is.
And the uterus has these 3 layers, right?
It does.
The middle layer is called the myometrium,
Yes.
which is made of smooth muscle.
That's a powerhouse.
And that's the layer that's responsible for those labor contractions.
Exactly.
And then the inner layer is the endometrium,
Mm-hmm.
which is so interesting because it goes through all these changes during the menstrual cycle.
Oh, yeah, big time.
It thickens to get ready for pregnancy.
Prepares a nice little environment for that fertilized egg.
Yeah, a cozy nest.
Exactly.
But if pregnancy doesn't happen, the endometrium sheds
Yep, that's menstruation.
and the cycle starts all over.
It's amazing.
It is. So we've talked about all these internal structures.
Mm.
What about the outside?
Yeah, the external anatomy.
The vulva,
The vulva.
which has the labia majora and the labia minora.
Right, for protection and sensation.
It's so important.
It is. And don't forget that the vulva is part of this bigger structure called the pelvic floor.
Oh, yeah, the pelvic floor. What's that exactly?
It's this intricate network of muscles and tissues that support all the pelvic organs.
So like the bladder and the rectum.
Exactly. It's almost like a hammock.
A hammock.
Yeah, holding everything in place.
Okay, I can picture that. So what happens if the hammock weakens?
Uh-oh.
Is that a problem?
It can be.
What could happen?
Well, you could have something called uterine prolapse, which is where the uterus starts to descend into the vagina.
Oh, wow.
Yeah, and it's often associated with childbirth because the perineum, which is that area between the vaginal opening and the anus,
Right.
it can get stretched and weakened during delivery.
So taking care of your pelvic floor is really important, especially after childbirth.
Really important.
Okay, well, while we're on the topic of interesting anatomy,
Mm-hmm.
let's talk about breasts.
Okay.
A lot of people don't know that breast size actually isn't related to milk production.
That's right.
Really?
It's mostly determined by the amount of fatty tissue.
So someone with smaller breasts can make just as much milk as someone with larger breasts.
Exactly.
Interesting.
And even when a woman's not lactating,
Mm-hmm.
her breasts still have this, like, rudimentary duct system.
Oh, so it's like the plumbing is already there.
Yeah, just waiting to be activated.
And what activates it?
Hormones, estrogen and progesterone.
So estrogen's responsible for the ducts growing and branching out.
It builds the infrastructure.
And then progesterone develops the alveoli, which are the milk-making factories.
You got it. The lactating breast is a marvel of engineering.
I can imagine. So those alveoli, they cluster together into lobes,
Mm-hmm.
and each lobe has a duct leading to the nipple.
Yep.
And what about the areola?
The areola, well, it's darker, right?
Yeah, why is that?
It actually helps babies find the nipple
Oh,
because, their vision isn't great when they're first born.
that makes sense.
And it's full of nerve endings that trigger milk ejection.
Oh, wow. Talk about efficiency.
It's amazing.
It is, like the body just knows how to feed a baby.
It's incredible.
All these amazing transformations.
Hormones are powerful things.
You are.
Tiny little chemical messengers that control so much.
It's pretty wild.
It is. And they play a huge role in this whole reproductive symphony.
Oh, yeah, like how they're produced and regulated by the hypothalamus,
Yes, the hypothalamus.
the pituitary gland,
Mhm.
and
Yeah.
the ovaries.
All working together.
It's like this complex dance,
It really is. It's a delicate dance.
with each hormone playing a specific part.
a specific part, absolutely.
So we have the hypothalamus,
Mm-hmm.
which is like the conductor,
The conductor.
the pituitary gland, which is like the first violinist,
Right.
and then the ovaries, which are like the powerful vocalists.
Producing all those hormones like estrogen and progesterone.
They're the stars of the show.
They are.
And these hormones all interact in such intricate ways throughout the whole menstrual cycle.
Mm.
They orchestrate the egg development and release,
Yep.
the uterus getting ready for pregnancy,
Uh-huh.
and then the shedding of the lining if pregnancy doesn't happen.
It's amazing.
It is. Okay, so I'm ready to delve deeper into this whole hormonal symphony.
Let's do it.
Let's start with the ovarian cycle, where an egg develops and is released during ovulation.
The ovarian cycle is fascinating.
What are the main phases?
So there are two main phases.
Right.
The follicular phase and the luteal phase.
Okay, tell me about the follicular phase.
Well, it's all about preparing an egg for release.
Got it.
So the pituitary gland releases FSH, which is follicle-stimulating hormone,
Mm-hmm.
and that stimulates the growth of follicles in the ovaries.
And each follicle has an immature egg, right?
And as the follicle grows, it produces estrogen.
So what happens when the follicle grows and estrogen levels rise?
Well, eventually estrogen levels get to a certain point,
Okay.
and that triggers a surge of LH, luteinizing hormone from the pituitary gland.
Mm.
And that LH surge, that's what triggers ovulation.
So ovulation is like the big finale of the follicular phase.
It is. It's the release of that mature egg.
But doesn't the egg only have a short time to be fertilized?
That's right. It only has about 12 to 24 hours.
Wow, that's not a lot of time.
It's a tight window.
So timing is everything.
It really is.
Yeah.
If it's not fertilized within that time, it disintegrates.
Okay, so after ovulation, what happens?
We enter the luteal phase.
Okay.
The ruptured follicle changes into something called the corpus luteum.
That's a fun word to say.
It is. And it starts producing progesterone.
Ah, progesterone. That's important for pregnancy, right?
Yes. It gets the endometrium ready.
Makes it thick and nutrient-rich.
Exactly. But if fertilization doesn't happen,
Oh.
the corpus luteum starts to break down.
Oh, no.
Progesterone drops,
Mm-hmm.
and the endometrium sheds, which leads to menstruation.
So it's like the ovarian cycle is all about getting the egg ready,
Mm-hmm.
and the menstrual cycle is about getting the uterus ready.
That's a great way to think about it.
It's amazing how they work together.
It really is. 2 cycles, perfectly in sync.
All thanks to these hormone fluctuations.
It's incredible.
It is. So we've covered the basic anatomy and the hormones.
Mhm.
What happens if an egg actually gets fertilized?
That's when the real adventure begins. The incredible journey of pregnancy.
That's a whole other story.
It is.
We'll have to save that for next time.
I can't wait. Welcome back to our deep dive, into the female reproductive system.
Last time we left off on kind of a cliffhanger.
We did.
That moment when a sperm meets an egg
Ah, yes.
and pregnancy begins.
Such a pivotal moment.
It is. I'm excited to hear all about how this tiny fertilized egg turns into a baby.
It's quite a journey.
It is. Where do we even start?
Well, it all begins with fertilization,
Okay.
which usually happens in the fallopian tube.
Right.
That fertilized egg, which we call a zygote,
A zygote.
starts dividing rapidly,
Really?
like super fast.
Wow.
And it's making its way down the fallopian tube toward the uterus.
So it's like it's on a mission.
Exactly, on a mission.
This little ball of cells.
I know. It's incredible.
So by the time it gets to the uterus, what does it look like?
Well, it's transformed into a blastocyst by then.
A blastocyst.
Yeah, it's basically this hollow ball of cells that's ready to implant.
Implant in the uterine wall.
Exactly. And that moment of implantation, that's when we officially say pregnancy begins.
That's so cool. It's amazing how much happens in just a few days.
It's remarkable.
It is. So once it implants, then what?
Well, then the body starts to change in all these incredible ways
To support the pregnancy?
to support and nourish that developing fetus.
And pregnancy is divided into trimesters, right?
Yes, 3 trimesters.
What are some of the milestones in each trimester?
Well, the first trimester is all about laying the foundation.
Okay.
A lot of development happens really quickly.
Like what?
Well, the major organs are forming.
Oh, wow.
The placenta develops,
Mm-hmm.
and the body starts producing HCG.
HCG. That sounds familiar. Isn't that what pregnancy tests detect?
That's right. It's produced by the developing placenta,
Okay.
and it tells the mom's body that she's pregnant.
So it's like the embryo is sending a signal.
Exactly. Like, hey, I'm here. Time to get things ready.
I love that.
And then in the second trimester, the fetus starts growing a lot bigger.
I bet.
And the mother often starts feeling those first little movements.
Oh, the quickening.
Yes, those first flutters.
What an amazing feeling.
It's magical.
And then the uterus starts having those practice contractions, right?
Oh, you mean the Braxton Hicks contractions?
Yeah, those.
Yeah, it's like the uterus is warming up.
Exactly, like getting ready for the big day.
Exactly.
And then finally the third trimester.
The home stretch.
I know. What happens then?
Well, both the mother and the baby gain a lot of weight.
Makes sense.
The baby's lungs mature.
To prepare for breathing.
Right. Everything is getting ready for labor and delivery.
It's pretty mind-blowing
It really is.
to think about all this happening at the same
And
time.
let's not forget about the hormones.
Oh, right. The hormones. They're still playing a big role, aren't they?
Huge role.
What are they up to in pregnancy?
Well, we talked about HCG, right?
Yeah. The pregnancy hormone.
But it can also cause morning sickness.
Oh, right.
That's so fun.
Definitely not fun.
But it's a reminder that those hormones are working hard.
Creating a good environment for the baby.
Exactly. And then estrogen is busy promoting breast growth and increasing blood flow.
To get ready for breastfeeding.
Right. And progesterone, well, it helps prevent premature labor by keeping the uterus relaxed.
So estrogen's like the construction crew.
I like that.
Getting everything built.
And progesterone's the peacekeeper.
Keeping everything calm.
It's a great analogy.
And there's another hormone, relaxin.
Oh, yes. Relaxin. It softens the ligaments and prepares the pelvis for birth.
It's like the body is going through a total renovation.
It really is. But those renovations can come with some side effects.
Oh, yeah, like what?
Well, in the first trimester, nausea and fatigue are common,
Right.
increased urination,
Makes sense.
breast tenderness.
Yeah.
And then as the baby grows, you might experience back pain and shortness of breath.
Oh, that makes sense as the uterus gets bigger.
Exactly. It puts pressure on other organs.
It's a lot for the body to handle.
It is. But it's amazing how adaptable the female body is.
It really is. So we've talked about all the changes leading up to labor.
Mm-hmm.
What actually happens during labor and delivery?
Labor is the process of bringing that baby into the world.
Okay.
And it's divided into 3 stages.
Okay.
The first stage is all about getting the cervix ready.
Ready for the baby to come through?
Exactly. It has to dilate and efface.
What does that mean?
It means it thins out and widens.
So it's kind of like a flower opening.
I like that. A blooming flower.
And during the stage, the mother has contractions, right?
Yes, those tightening sensations.
To help dilate the cervix.
Exactly. And they get stronger and more frequent as labor goes on.
So the first stage is all about the cervix.
Yep.
What's the second stage?
The pushing stage.
So that's when the mom starts pushing.
Exactly. She works with her body to help the baby move down.
And all those practice contractions probably come in handy.
They do.
So as the baby moves down, what happens?
Well, there's a point called crowning,
Crowning.
which is when the baby's head starts to emerge.
Wow.
And then with one final push, the baby is born.
That must be such a relief.
It is. But even though the baby is here, there's one more stage.
Oh, right. The placenta.
Yes, the placenta has to be delivered.
It's been nourishing the baby all this time.
Exactly.
So the umbilical cord gets cut.
Mm-hmm.
The placenta detaches. And then it's expelled.
It's the final act.
I know. It's amazing how the body just knows what to do.
It's incredible.
And those hormones are still hard at work.
Oh, absolutely. Oxytocin, for example.
Oxytocin, that's the love hormone, right?
Yes. It stimulates those uterine contractions.
Yeah.
And after birth, It helps with milk ejection.
Wow, so it's involved in labor and breastfeeding.
It's a busy hormone.
It is. It's fascinating how hormones play such a crucial role throughout the entire process.
From conception to birth and beyond.
And speaking of beyond,
Yes.
we've been talking about the biology of all this,
Mm-hmm.
but there's another layer to this story, isn't there?
There is. We've been focused on the biological aspects,
Right.
but we can't forget about the social and cultural context.
That's a great point. The way we view and experience our bodies is influenced by so much more than just biology.
Exactly.
Welcome back to our deep dive.
Back for more.
I know, we've covered so much already about the female reproductive system.
It's been quite a journey.
It has. We've talked about all the biological stuff, the hormones and the amazing journey of pregnancy and childbirth.
All the incredible workings.
But there's another layer to this whole story that we haven't really touched on yet.
You're right. We've been focusing on the biology,
Right?
but the social and cultural context is so important too.
It's true. I mean, it really shapes how we see and experience our bodies.
Absolutely.
It's like we've been looking at the hardware.
The nuts and bolts.
Exactly, the nuts and bolts of this system.
Now it's time to talk about the software.
The programming.
Right. The cultural programming that influences how we understand it all.
Exactly. Like take menstruation, for example.
Okay.
It's a natural biological process.
Absolutely.
But in so many cultures, it's like this secret thing.
It's shrouded in secrecy and stigma.
Yeah. Like I remember growing up, it was something we whispered about,
Right.
not something we talked about openly.
Not at all.
It was almost like it was something to be ashamed of.
And in some cultures, menstruating women are seen as unclean
Really?
or even dangerous.
Wow.
They have all these restrictions.
That's so interesting.
It's almost like society is trying to erase this essential part of being female.
I know. It makes you wonder what's behind all that discomfort.
It's something so natural.
Yeah.
I think there are a lot of historical and cultural factors at play.
Right. But all that silence and shame,
Mm-hmm.
it can really impact women.
Absolutely.
It can lead to anxiety,
Yeah,
even a disconnect from their own bodies.
it's really sad.
It is. I think that's why open dialogue and education are so important.
I agree.
We need to, break down these taboos and empower women.
To understand their bodies.
Yeah, to understand and embrace their bodies.
Without shame.
Exactly. And knowledge is power,
It really is.
especially when it comes to reproductive health.
Being informed can be so liberating.
Totally. It lets you advocate for your own health.
You can make informed decisions.
Right, and challenge misinformation.
That's so important.
It is. And it goes beyond just individual empowerment, too.
Oh, absolutely.
It helps us advocate for better healthcare and policy.
Now, all women.
Right.
Like, think about the disparities in access to reproductive health care.
It's a huge issue.
It is. In many parts of the world, women face all these barriers to contraception,
Yeah.
safe abortion.
And even basic prenatal care.
That's heartbreaking.
It is. And those disparities, they often stem from social and economic inequalities.
Exactly.
It makes it clear that reproductive justice is about way more than just access to healthcare.
It's about so much more.
It is. What is reproductive justice exactly?
It goes beyond the right to choose.
Okay.
It's about making sure that all
No
women
matter what their background is.
have the resources and support they need.
To make informed decisions about their bodies.
Exactly. About their bodies and their lives.
So it's not just a personal issue.
Yeah.
It's a social justice issue.
It affects us all.
That brings us back to education and advocacy. We need to challenge those harmful stereotypes.
Yes.
Dismantle systemic barriers.
And create a world where all women have the freedom to control their reproductive destinies.
Exactly. So what can we do on an individual level to promote reproductive justice?
Well, I think the first step is to educate yourself.
Okay.
Learn about the issues
Engage in conversations.
and challenge your own biases.
That's a great starting point. And I imagine supporting organizations that are fighting for reproductive rights is important too.
Oh, absolutely. Donate your time or money.
And most importantly, use your voice.
Yes. Speak up.
Advocate for change.
And don't be afraid to challenge the status quo.
It's about recognizing that our bodies are not battlegrounds.
They are sources of strength and empowerment,
It's about reclaiming our narratives,
and shaping a future where reproductive health is celebrated.
not stigmatized.
Exactly.
Well, this deep dive into the female reproductive system has been fascinating.
I've learned so much.
Me too. We've gone from the microscopic details of egg development
To the big picture.
to the social and cultural landscape.
It's all connected.
It is. We've explored the biology,
The hormones.
the incredible power of the female body,
And we've talked about the importance of education and advocacy.
and a holistic approach to reproductive health.
It's about seeing the whole picture.
I hope this deep dive has left everyone feeling informed
And empowered.
and maybe even a little bit in awe of the female reproductive system.
It is awe-inspiring.
It is. Remember, knowledge is power.
Share what you've learned.
Keep exploring.
And never stop advocating.
For a world where all women have the freedom and the resources to make informed choices about their bodies and their lives.
That's what it's all about.
It is. And that brings our deep dive to a close.
Until next time.
Stay curious, everyone.
Welcome back to the Deep Dive. Today we're tackling home dialysis. You wanted to get a handle on this, so we dug into some guides, the latest research and medical stuff to get you the need-to-know info. And, well, it's a lot more interesting than you might think.
It is. There's a lot more to home dialysis than what we see on TV, that's for sure.
Yeah, for sure. So before we get into the specifics, let's just step back for a sec. Did you know that 4.4 million adults in the U.S. are dealing with kidney disease? And get this, that number is growing like 8% each year.
It is a major concern, and it's not just about, people aging. I mean, of course, conditions like diabetes and high blood pressure play a role, but what's interesting is that kidney disease is increasing in younger folks too, so that raises some questions about lifestyle. And early detection, of course.
For sure. So can you remind us what the kidneys even do? Why are they so important?
Oh, absolutely. Think of your kidneys as your body's, super efficient filter. They're constantly working, cleaning your blood, taking out waste and excess fluid, keeping your body's chemistry in balance. They even regulate your blood pressure and tell your body to make red blood cells.
They're like the unsung heroes of our organs. So what happens when they start to fail?
Well, you might start seeing signs like fatigue, right? Or loss of appetite, maybe some swelling. As kidney function declines, waste builds up in the blood, which is called uremia. When it gets to that point, there are a few options. There's dialysis, kidney transplant, or palliative care. We'll focus on home dialysis today.
Perfect. Now, there are two main types of home dialysis, right? Peritoneal dialysis and home hemodialysis. What's the difference?
Yeah, so both types basically do the same job. They filter the blood, but they do it in very different ways. Peritoneal dialysis, or PD, is like having a filter inside you. It uses the lining of your abdominal cavity, called the peritoneum, to remove waste and excess fluid.
Like a built-in backup system. So how does it work?
It's pretty ingenious. A special solution, we call it dialysate, is put into the abdominal cavity through a catheter. It's surgically implanted. This solution just sits there for a while, drawing the waste products and extra fluid from the blood vessels in the peritoneum. And then the used solution is drained, and we repeat.
It's like a continuous clean happening right inside you.
Exactly. And there are two main types of PD, CAPD and CCPD. CPTD, it stands for Continuous Ambulatory Peritoneal Dialysis. It's done manually several times a day. The patient connects to bags of the solution, the dialysate, and it sits in their abdomen for a few hours, and then they drain it out.
So they can go about their day.
Right. Patients on CAPD can usually do their normal things. The exchanges, that's what we call them, take about 30 to 40 minutes, and they can be done anywhere. Home, work, even while traveling.
That's great. What about CCPD?
CCPD, or continuous cycling peritoneal dialysis, is done with a machine called a cycler. The cycler does the exchanges automatically during the night while the patient sleeps, so they wake up with fresh solution and they're good to go.
Convenient. So all PD patients have this special catheter implanted.
Yep, the catheter is crucial for accessing the peritoneal cavity. It's a small tube, very flexible, that's surgically placed, usually in the lower abdomen. It's got a cuff on it that helps keep it in place and prevents leaks.
I bet placement of that is pretty important.
It is. The surgeon picks a spot that minimizes the risk of anything going wrong and makes sure the catheter will work right. There are, different types. Some are straight, some are coiled, and they all have tiny holes at the tip.
Yeah.
That allows the fluid to move.
So it's the entry and exit point for that cleaning fluid.
Yeah.
What about the outside? What do they use to actually connect to the dialysate?
So for CAPD, they connect the catheter to a transfer set. It's basically just tubing that connects to the bags of dialysate.
Mm-hmm.
And gravity does the work, filling and draining. No machine needed.
Low tech.
Kind of, but there's a lot of precision involved. The patient has to be super careful to prevent infections, sterile techniques, and they measure and record how much fluid is exchanged.
I bet the details matter here. What about the transfer set? Are there parts we should know about?
Yeah, it has a mini cap, and that has a sponge in it that sterilizes the connection point, between the catheter and the tubing. There's also a twist clamp, and that lets them control the flow.
So that's like a little valve.
Exactly. Simple, but so important. Now imagine, you're an EMT and you get a call for a PD patient. Sometimes you might need to disconnect them from their system.
That's where it gets tricky. So first, let's talk about CIPD. How do you disconnect them safely?
The most important thing is to close that twist clamp. Then you clamp the tubing to the bags, disconnect the patient's tubing from the bag, and secure the patient's side tubing, covering it with a sterile abdominal pad.
So it's twist clamp first, then clamp, and disconnect.
Got it.
What about CCPD?
Oh, with CCPD, because you have the cycler, you got to turn off the power to the machine first. Then it's similar to COPD. Close the twist clamp, disconnect the patient tubing from the machine, and secure it with a sterile pad.
Same basic idea, but with the cycler. What if it's a real emergency? Is there a faster way?
Yeah, in those cases, it's clamp, cut, and run. It's a rapid disconnect technique.
Okay, so how does that work?
So you clamp the extension line and the catheter with either a twist or roller clamp, and then you cut the tubing in between. Never, ever cut the transfer set or the catheter, just the extension lines.
So you're disconnecting them quickly and safely. Got it.
Right. Now, a sterile mini cap on the transfer set is better than cutting, but only if you can clamp the catheter.
So whether it's CIPD or CCPD, we need to disconnect them without damaging the catheter and prevent infection.
Exactly. Always secure the disconnected tubing with a sterile abdominal pad and watch out for peritonitis. It's an infection of the peritoneum.
We don't want that. Okay, so we've
Yeah.
talked peritoneal dialysis. We need to talk about home hemodialysis.
We do, and that's where it gets a little more high-tech.
Okay, so home hemodialysis, or home HD, this is what people usually think of, right? The machine, the needles, how does it work?
So home HD filters the blood outside the body. It uses a machine called a dialyzer. It acts as an artificial kidney, like a detour to get your blood clean and balanced. For that to happen, the patient needs special access to their bloodstream.
And that's where the needles come in.
Right. There are 3 types of vascular access for home HD: fistula, graft, and a central line. They all have pros and cons.
Let's break those down. First, what's an AV fistula?
An AV fistula is, well, it's the best way to get vascular access. It's made by connecting an artery and a vein. Surgically, of course, usually in the forearm. That lets the vein get bigger and stronger, so it's easier to put needles in for dialysis.
You're creating a new pathway for blood flow. Why is that the preferred method?
Well, it has the lowest risk of infection or clotting, and it's super durable. It can last for years if you take good care of it.
Reliable and long-lasting.
Hmm.
What about AV grafts?
So AV grafts are used if the patient's veins aren't good enough for a fistula. Too small or weak, maybe. A graft is like an artificial blood vessel put under the skin to connect an artery and vein. It's usually made from synthetic stuff, sometimes from an animal donor.
So it's the backup if a fistula is impossible.
Hmm.
Do they work as well?
Same principle. It's a place to put the needles, but there's a slightly higher risk of clotting or infection compared to the fistula.
Okay, so fistula first, graft, if that doesn't work. And then there are central lines. What are those?
A central line is a catheter, and it goes into a large vein, usually in the neck or chest, and the tip sits in a vein close to the heart. They're usually temporary, like if someone needs to start dialysis right away or while they're waiting for a fistula or graft to, mature.
So good for the short term. Not the best long term.
Right. Higher risk of infection and stuff.
Okay, so those are the access types. Let's talk about the machine. What is it and how does it work?
The home HD machine is often called the Domus, and it's basically like a mini dialysis center for your home.
It does the work that would normally be done in a center.
Yeah. Removes waste and extra fluid from the blood and puts the clean blood back in, and it helps regulate electrolytes and control blood pressure.
That's amazing. That must be so empowering for patients. But I bet there are a lot of safety concerns, right?
Oh, absolutely. Safety is so important. Home HD machines have a lot of safety features built in, like the hemodialert. It detects leaks in the blood lines.
So if the needle comes out or a line kinks, it sounds an alarm.
Yep. And there are safety clamps, and they lock the lines. And there's the Zircon. It detects water leaks from the machine or the water purification system.
It's got a lot of safety features.
It does, and they're so important. Home HD is, more unsupervised, so it's good to have those layers of protection. It gives everyone peace of mind.
I see that. Now, just like PD, there are times when you, as an EMT, might need to disconnect a patient from their home HD machine. How do you do that?
So first, turn off the main power switch on the Domus. Then you put clamps on the blood lines and cut between the clamps.
We're cutting the lines, just like with PD.
Yeah, but again, never cut the central line catheter itself, if that's what they're using. Only the blood lines to stop the blood flow.
Okay, what do you do next?
You got to secure the ends of the lines to their arm with tape to stop bleeding. And if you can, you want to flush the lines with saline-filled syringes. That prevents clotting.
Stop the flow quickly and safely.
Yes. And remember, the blood flow through a fistula or graft can be really high, like 500 milliliter per minute.
Wow, that's a lot of blood. And HT patients are at risk for low blood pressure. The dialysis takes up fluid.
You got it. So controlling the bleeding from that access site is super important.
Okay, we've covered the disconnect procedures for both. But what if you're not sure what kind of dialysis they're on? What are some reasons someone might call 911 for a dialysis issue?
Okay, so a few things to watch out for. Infection's a big one. It can show up in a lot of ways, like fever, chills, pain in the abdomen, redness or swelling where the catheter is, or even cloudy dialysis fluid.
Any signs of infection are bad news. What else?
Fluid overload is common. It happens when the dialysis isn't working right, or the patient isn't following their fluid restrictions. They'll be short of breath, swelling in the legs and feet, and maybe even trouble breathing when they lie down.
So infection, fluid overload, what else?
You also have cardiovascular issues, things like chest pain, irregular heartbeat, and even heart attacks.
Right, because their heart is working harder.
Exactly. And then, of course, there's bleeding. It can happen at the access site, especially with fistulas and grafts, or, internally if they have a bleeding disorder.
A lot of potential complications.
There are, but being aware of them is the first step.
Yes, definitely. So if we get called to a home dialysis patient, what are the key questions to ask?
You'll want to know what type of dialysis they're on, PD or home HD, and when they last dialyzed, and if there have been any problems.
Basic info about their dialysis. Anything else?
Symptoms, fever, shortness of breath, pain.
To get a sense of their condition.
Right. Medical history is important too. Other conditions like diabetes or heart problems. Do they see a specialist?
To help us figure out what to do.
Exactly. And good communication is so important. Tell the hospital staff everything you know.
Great point. Wow, this first part was packed with info. It's a lot to know.
It is. As home dialysis becomes more common, EMTs are going to see more of this.
And we're here to help you prepare. Now let's take a quick pause. We'll come back with even more insights into home dialysis. Stay with us. Welcome back to the deep dive. Now that we've got the basics of home dialysis down, let's talk about the stuff that can really go wrong, the situations where you, as an EMT, really got to be on your game.
Being prepared for those emergency scenarios, it's so important.
Totally. Okay, imagine this. You get a call for a home dialysis patient, and they're having trouble breathing, short of breath. What are you thinking as you head to the scene?
Well, I start thinking about what could be causing it, right?
Mm-hmm.
Could be something simple, like anxiety, but it could also be something more serious, like fluid overload, which is pretty common with dialysis patients.
So you're already thinking about how their dialysis might be involved.
Yeah. You have to keep that in mind as you assess everything. Once you get there, it's the ABCs, just like always. Airway, breathing, circulation.
The basics don't change, but you're looking at it through the lens of dialysis.
Right. So airway, make sure it's clear. Breathing, are they struggling? Circulation, that's the pulse. And blood pressure, got to check those.
And those vital signs can give you some clues.
Oh, for sure. Let's say their pulse is racing and their blood pressure is low. Could be internal bleeding, maybe a sudden drop in blood volume. Dialysis can cause that sometimes.
Yeah, so knowing how dialysis works can really help you put the pieces together.
It can. Don't forget to check blood sugar, too, if you have the equipment. A lot of these folks have diabetes, so that can make things even more complicated.
Okay, you're gathering all this information, figuring out what's going on. What about the dialysis equipment itself? Should we be messing with that as EMTs?
Good question. Most of the time, no. You don't need to touch the equipment. Your job is to get them stable and to the hospital.
We're not there to fix the machine.
Nope. But it does help to know, the basics of the different types of dialysis and what kind of equipment they use. Makes it easier to talk to the patient, their family, and the hospital staff.
Communication is key.
Always. So if you're transporting someone on peritoneal dialysis, for example, you want to let the hospital know what kind, CAPD or CCPD. And when they last had an exchange, that stuff matters.
Yeah, that makes sense.
Right.
Okay, different scenario. You get to the scene, and the patient's accidentally disconnected from their home HD machine.
Oh, that can be tough, especially if they have a fistula or graft that's bleeding. First thing, you got to control the bleeding. Direct pressure, elevate the arm.
Stop the bleeding, like we always do.
Exactly. But with dialysis patients, you got to be extra careful because they're at risk for clotting problems because of their kidneys. So keep a close eye on them. Watch for too much bleeding or any signs of clotting.
I bet their blood pressure can be all over the place in those situations.
Yeah, it can. Could drop suddenly from the blood loss, or it could spike if the treatment stopped too fast.
So we got to watch those vital signs like a hawk.
Definitely. And don't forget to be supportive, It can be scary for the patient, so stay calm and be reassuring.
It's about more than just the medical stuff.
Totally. Okay, let's switch gears again. What if you've got a peritoneal dialysis patient and they're having really bad abdominal pain and you see signs of an infection?
It sounds like peritonitis. That can be really bad.
It is. If it's not treated quickly, it can be life-threatening. So if you think it's peritonitis, get them to the hospital fast. In the meantime, just make them comfortable, manage the pain, and watch those vital signs.
Recognize it and get into the hospital ASAP. Got it. Now, this is just a quick look at emergencies in home dialysis. There's a lot more to it. Get out there, get some more training, read up on this stuff.
Yeah, for sure. The more you know, the better you'll be at handling these calls. And that means better outcomes for your patients.
Well said. Okay, let's take one last break. We'll be back with some final thoughts on home dialysis. Welcome back to the Deep Dive. As we wrap up our look at home dialysis, I want to talk about the people behind it, the patients themselves.
Yeah, it's so important to remember that. They're the ones living with this every single day.
Exactly. So imagine you get to a scene, and the patient is clearly frustrated. Maybe they're struggling with their dialysis equipment. How do you, as an EMP, handle that?
You gotta have empathy, It's not easy managing a serious medical condition at home. They're probably tired, stressed, maybe even a little scared. So just listening to them is huge.
So it's not about jumping in to fix the equipment.
No, not right away. Start by just acknowledging their feelings. You could say something like, "It sounds like you're having a tough time today. I understand how frustrating that can be."
Just validating what they're going through?
Yeah, it makes a difference. It shows them you care. And then once they've had a chance to vent a little, you can start asking questions. Try to figure out what's going on.
Okay, so asking open-ended questions. What's been difficult for you today? Something like that.
Exactly. And listen to what they say. Don't interrupt or try to solve the problem right away. Sometimes they just need to talk it out.
Makes sense. What about communication in general? Any tips for talking to home dialysis patients?
Keep it simple. No medical jargon. Remember, they're not doctors.
Right, so instead of hypotension, just say low blood pressure.
Exactly. Break down complex stuff into smaller pieces. You don't want to overload them with info.
Especially if they're already feeling overwhelmed. And give them time to ask questions.
All the time in the world. Don't rush. Let them ask anything. And if you don't know the answer, just be honest. Say, "I don't know, but I can find out."
So honesty and a willingness to help.
Yeah, it builds trust. And as EMTs, we're often the first people they see when something goes wrong. We can make a real difference in how they feel.
So we're not just there to treat a condition, we're there to care for the person.
Exactly. Treat them with dignity and respect. Be compassionate.
Okay, as we wrap up our deep dive into home dialysis, let's recap. First, it's becoming more and more common. We got to be ready for it.
For sure. And second, never underestimate communication. Really listen to your patients. Be clear and compassionate.
And finally, there's a ton of information out there. Use the resources available to keep learning about this.
We've got some great links in our show notes. Different types of dialysis, emergency procedures, even tips for talking to patients.
So check those out. And if you have any questions or topics you'd like us to cover, let us know. We love hearing from you.
Yeah, we do. Always happy to learn more.
All right, everyone, that's our deep dive into home dialysis. We hope you found it helpful and maybe learned something new.
Thanks for listening. It's been great.
And thanks for joining us on the deep dive. Until next time. Hey, everybody, welcome back for another deep dive.
Oh.
You guys have given us some really intense material this time.
Yeah.
We're dealing with a situation that's thankfully pretty rare, but when it happens, it's all hands on deck.
Right.
Maternal cardiac arrest, 2 lives on the line.
Absolutely.
So let's jump right in and break down what every paramedic needs to know to give both mom and baby the best possible chance.
It really is a unique challenge in emergency medicine.
Yeah.
2 patients totally dependent on each other. And the sources we've got this time make it very, very clear that the mother's survival is absolutely key to the baby's survival. So successful resuscitation for her means the best outcome for both.
That makes total sense, but it also adds like a whole other layer of pressure to an already incredibly intense situation.
Oh, yeah.
So where do we even begin to unpack this? What are the most common things that can lead to cardiac arrest in pregnant women?
Well, the training material uses a a mnemonic,
Oh, I love those.
yeah, to help us remember BOPSOPS.
PSOPS.
All right, let's break that down.
Oh.
So that stands for bleeding obstructed labor, pulmonary embolism, seizures, things like eclampsia,
Oh.
and then sepsis, other causes placenta issues, and finally systemic causes.
BOPSOPS. Gotta love a good mnemonic. But some of those categories seem pretty broad, especially, other and systemic.
Yeah.
What kind of surprises are lurking in there that paramedics need to be ready for?
You're right. Those are really broad categories. And I think that's one of the reasons why this deep dive is so important
Yeah.
because, things like aortic dissection, even something like aspirating vomit can lead to cardiac arrest, specifically in pregnant women.
Wow. It's not always the most obvious causes.
Right.
So, good reminder to always keep that wide lens on our differential diagnoses,
Yeah.
especially in such a dynamic situation. Now, let's talk about speed.
Okay.
The source material really hammers that home, doesn't it?
It does. Absolutely. Time is critical. The sooner we can get mom to a facility that's equipped for a perimortem C-section, the better the chances of survival for both patients. The research suggests that for every minute of delay in performing that C-section, the mother's chances of survival decrease dramatically.
Wow, every minute counts.
Yeah.
All right, so let's say you arrive on scene, lights and sirens. You've got a pregnant woman in cardiac arrest.
Okay.
What are the immediate differences in your approach to CPR compared to a non-pregnant patient?
Well, one of the biggest considerations is aortal caval compression. So the weight of the uterus, especially later in pregnancy, can actually press on a major vein, restricting blood flow back to the heart. So we need to adjust our CPR technique to account for that.
So how do you actually do that in the field? It sounds like it would require an extra set of hands.
You're exactly right. Ideally, you would have someone manually displace the uterus, so gently shifting it to the left. While another person performs chest compressions, there are specific techniques for this, using one or two hands, and clear communication is vital.
Got it. Teamwork is key. Now, what if you're short-staffed and can't maintain that manual displacement the whole time? What's the backup plan?
Well, the source recommends transporting the patient tilted at least 30 degrees to the left. This position helps relieve pressure on that major vein,
Okay.
but it definitely makes giving effective compressions more challenging.
It's a tough call balancing the benefits of each approach.
Yeah.
So you've addressed the circulation issue. Now, let's talk airway. What makes airway management trickier in pregnant patients?
Think about it this way. Pregnancy causes all sorts of hormonal changes.
Okay.
And one of these side effects is increased blood flow and swelling, even in the airway. So that means getting a breathing tube in can be more difficult. It often requires a smaller tube and a more experienced hand.
It's like trying to thread a needle in a moving car. That's a great analogy. So you got to be extra careful and deliberate with your approach.
You do.
Now, what about medications and fluids? Are standard cardiac arrest protocols still applicable?
The good news is yes. Defibrillation and the usual medications are considered safe during pregnancy. 5E access, however, is another area where we need to adjust our thinking.
Okay, what's the key difference there?
We want to establish that IV access above the diaphragm,
Hmm.
ideally in the arms or upper chest. And this is because the enlarged uterus can actually obstruct blood flow from the lower half of the body.
It's all about working with the anatomy, finding the most efficient route.
Absolutely.
So we've got our basic understanding down. But I always find that real-world examples really help solidify things. And luckily, our source material includes a pretty intense case study.
Yes, it does.
Yeah.
It walks us through a scenario involving a pregnant woman involved in a car crash. And things take a turn for the worse very quickly.
All right, set the scene for us. What did the paramedics walk into?
They get dispatched to a single vehicle accident, car versus tree. The driver unfortunately didn't make it. The passenger, a pregnant woman, is conscious but fading fast.
So you've got a chaotic scene, a critically injured patient, and that clock is ticking. What are the immediate priorities in that situation?
First and foremost, they're focused on her ABCs. Airway, breathing, and circulation. They need to control any bleeding, get vital signs, and maintain spinal immobilization all at the same time. It's a lot to juggle.
I bet. What do they find during that initial assessment? That any red flags that jump out right away?
Well, she's pale drifting in and out of consciousness, and there's some blood visible inside the car. Her vitals are concerning heart rate, elevated blood pressure dropping, and her oxygen saturation is low.
Sounds like a recipe for disaster.
Yeah.
What steps do they take to stabilize her?
The fire department arrived to help extricate her from the car, which gave the paramedics better access for assessment and treatment.
Right.
Once they had her out, they discovered abdominal bruising, vaginal bleeding, and bleeding from her legs.
Okay, so multiple injuries, potential for serious blood loss. What did they learn about the pregnancy itself?
She was about 36 weeks along, first pregnancy, no previous complications. Importantly, she wasn't in active labor at that point.
Good to know. So how did they manage all those injuries while keeping in mind the potential impact on the baby?
They addressed the external bleeding with pressure dressings. They positioned her on her left side to relieve that aortal cavil compression we talked about. And they started gathering information about her due date and any relevant medical history.
It sounds like they were anticipating that things could go south quickly. Were they right?
Sadly, yes. Her
Mhm.
condition continued to deteriorate. They were just about to transport, and then she went into cardiac arrest.
Everything changes in an instant.
It does.
What happens next? This is where that specialized training really kicks in.
They immediately confirm she's pulseless and start CPR. Remember how they prepped the defibrillation pads earlier? That foresight saved precious time, allowing them to deliver the first shock quickly. Of course, someone is also assigned to maintain manual displacement of the uterus throughout the resuscitation efforts.
Wow, it's all hands on deck, everyone working in sync. Did they manage to get her to the hospital?
They did. And thankfully, the ER team was prepped and waiting for them, ready to take over.
Phew, that's a relief. Okay, we're going to pause the action right there. Join us for part 2 of this deep dive, where we'll see what happens once they reach the hospital. And we'll delve deeper into the world of post-arrest care.
Welcome back to the deep dive. We left off with our patient arriving at the hospital, a whirlwind of activity going on in the back of that ambulance. But surviving the initial arrest
You're right.
is just the first step in a long road to recovery, right? What does post-arrest care look like when we're dealing with a pregnant patient?
Yeah, you're absolutely right. It's not over when the heart starts beating again. And when it comes to moms in this situation, there are some unique things we need to keep in mind.
Okay.
For instance, these patients are often hypotensive post-arrest, meaning their blood pressure is dangerously low.
So how do you tackle that? It's not like you can just crank up the fluids without thinking about the
Logically.
baby, right? We still need to be mindful, but establishing IV access above the diaphragm, either in the arms or the upper chest, is crucial. This ensures that fluids and meds have a clear path to reach the heart without being slowed down by the enlarged uterus. Sometimes we even need to use an IO. That's intraosseous injecting directly into the bone marrow if we can't get a vein.
Okay, so fluids are key, but we're giving them strategically. What about the airway? Is that still a primary concern even after we've got a pulse back?
Absolutely. Remember, pregnancy speeds up the development of hypoxia, which is a lack of oxygen, so maintaining that open airway is vital. In the post-arrest period, we talked earlier about how intubation, putting in a breathing tube, can be tricky with pregnant patients.
Right, all that swelling and hormonal changes make it a tougher procedure. So what happens if you can't get the tube in? What are the alternatives?
In those situations, a supraglottic airway can be a lifesaver. It's a device that sits above the vocal cords, helping to keep the airway open. It's not as secure as a breathing tube, but it can buy us some time until we can get to a more definitive solution.
It's like having a backup generator when the power goes out.
Exactly.
Always good to have a plan B. Now, we've talked a lot about medications being safe for mom and baby during cardiac arrest,
Right.
but what about pain management afterward? That seems like it would be a tricky area.
You're right. That's a really important consideration. While our sources don't specifically address pain management in this context, we know it's a crucial aspect of post-arrest care overall. I think it's safe to assume that the same principles would apply to pregnant patients,
Yeah.
though further research would be valuable.
It makes sense. I mean, uncontrolled pain can definitely hinder recovery for anyone. And we don't want to add extra stress to an already delicate situation.
Right.
Now, something you mentioned earlier really caught my attention. The importance of getting a 12-lead ECG
Yes.
after the patient is stabilized. Why is that so crucial in these cases?
That 12-lead ECG can give us valuable clues about what triggered the cardiac arrest in the first place. Was it a heart attack, a rhythm problem, something else entirely?
So it's like detective work trying to piece together the events leading up to the arrest. And that information can guide further treatment decisions, right?
Exactly. Knowing the underlying cause can help us tailor our approach to prevent future cardiac events. For instance, if we discover she had a blocked artery, we might need to consider procedures like angioplasty or stenting.
So let's take a step back for a moment and recap what we've learned so far
Okay.
about managing maternal cardiac arrest.
We've seen that it's a complex scenario, requiring specialized knowledge and skills.
Yeah.
It's not just about resuscitating the mother, it's about understanding the physiological changes of pregnancy and how they impact every decision we make.
We've talked about adapting CPR techniques, considering alternative airway strategies, and being mindful of IV access and medication administration.
Right.
And we've emphasized the importance of post-arrest care, especially managing blood pressure.
Yeah.
And maintaining that open airway.
And we can't forget about that 12-lead ECG, giving us a peek into what might have caused the arrest and guiding our future treatment plan.
We've covered a lot of ground, but there's still more to explore. In Part 3, we'll shift our focus to the factors that can ultimately determine the outcome of these high-stakes situations. What makes the difference between a happy ending and a tragic loss? Join us for the final part of our deep dive into maternal cardiac arrest. Welcome back for the final part of our deep dive into maternal cardiac arrest. We've walked through the initial response, the crucial steps of post-arrest care. But now I want to talk about the bigger picture. What are the factors that really make or break a successful outcome in these situations? What tips the scales towards survival for both mom and baby?
That's the million-dollar question, isn't it? And unfortunately, there's no easy answer. Our sources don't offer a magic formula because it's always going to be a complex mix of variables.
Right.
But we can definitely learn from that dramatic case study we discussed, the pregnant woman in the car crash.
Yeah.
What aspects of that response stood out to you as potentially life-saving?
Well, the first thing that jumps out is the paramedic specialized training. They knew exactly how to modify CPR, how to approach the airway, how to think about IV access differently, because they were dealing with a pregnant patient.
Exactly. They weren't just applying generic protocols. They were adapting their knowledge to the specific situation. And it wasn't just about knowing the steps. It was about anticipating problems before they arose.
Yeah.
Like having the defibrillator pads ready to go. That kind of foresight can save precious seconds when every heartbeat counts.
It's like they were playing chess, thinking several moves ahead. And let's not forget the importance of teamwork.
Oh, absolutely.
It wasn't just the paramedics. It was the bystanders calling 911, the fire department extricating her from the car, the ER team waiting at the hospital. Every single person in that chain of survival played a role.
Couldn't agree more. You need that seamless communication, that coordinated dance between everyone involved to give mom and baby the best chance. One weak link in the chain can have devastating consequences.
And speaking of choreography, think about the importance of getting her to a hospital that was equipped for a perimortem C-section.
Right.
That's a procedure most hospitals don't do every day.
Exactly. It requires a specialized team, the right equipment, the ability to act fast. Our source material really highlights that perimortem C-section, performed within minutes of the arrest, can dramatically increase the chances of survival for both patients.
It's a stark reminder that not all hospitals are created equal. Sometimes getting to the right facility is just as important as the care you provide en route.
Yeah.
So to recap, we've got specialized, training effective teamwork, early access to advanced care, and underlying it all, the rapid initiation of life-saving interventions. Every second matters.
You nailed it. It's about recognizing the urgency of the situation and acting decisively. But there's another piece of the puzzle that we haven't touched on as much, and it's something I think about a lot.
I'm all ears. What is it?
The emotional and psychological impact this kind of event has. We can't forget about the trauma experienced by the mother, her family, even the first responders.
That's so true. We tend to focus on the physical aspects of survival, but the mental and emotional scars can run deep.
Absolutely. And how we support those affected, how we provide resources for healing, that's all part of providing truly comprehensive care. Perhaps that's a deep dive for another episode.
I think you're onto something there. Well, on that note, it feels like we've reached the end of our exploration. We've covered a lot of ground today.
We have.
From that initial shock of seeing that flatline to the long road of recovery that lies ahead, it's been a fascinating journey dissecting this complex topic.
It has. You know, it always amazes me how much we can learn from just a few well-chosen sources.
Me too. And I hope our listener has come away with a deeper understanding of just how intricate and high-stakes maternal cardiac arrest is. It's a reminder that we need to constantly be learning, honing our skills, and advocating for the resources that can make a difference in these critical moments.
Couldn't have said it better myself. Until next time, keep those minds sharp and keep diving deep.
All right, diving right in today. We're tackling pregnancy complications. You've sent over an audio lecture, right? Pre-delivery emergencies. Really fascinating stuff.
Oh, yeah, it gets pretty intense.
For sure. Yeah, we're going to break it down. Really want to help folks grasp all the ins and outs of what can happen. Pregnancy is amazing, but...
Absolutely, but it's not always, smooth sailing.
Nope.
Got to be prepared.
Right. Being informed, not freaking out, that's the key takeaway.
Oh.
And this lecture really stressed how EMTs have a tough job when it comes to pregnant patients.
Yeah, they got to think about two patients at once, basically. mom and baby. That changes everything.
For sure. They were saying, like, even blood loss. A
Mhm.
pregnant woman can lose more before it's obvious, right?
Exactly. Their blood volume naturally goes up. So you can't just rely on the usual signs of shock.
Makes you realize how much is going on behind the scenes, literally. And they really emphasize asking the right questions about bleeding, not just relying on what you see.
Oh, yeah, absolutely. Imagine, internal bleeding. You might not see much externally, but inside, it's a whole different story.
Scary stuff. So they got to ask detailed questions, like how long has it been bleeding? How many pads have you used? That kind of thing.
Exactly. Gonna piece together the whole picture, right? Like a puzzle.
And stay calm on top of that while someone's, potentially in a really scary situation.
For sure. It takes a lot of skill and, empathy.
Absolutely. Now, the lecture mentioned this acronym, GTPA,
Yeah.
pregnancy history, right? When I first started, I was like, what?
Sounds like a secret code, I know.
But it's actually pretty smart when you break it down. What does it stand for again?
Gravida. So how many pregnancies? Term births, preterm births, abortions, and living children. Gives a quick snapshot.
Wow, a whole reproductive history in just a few letters.
Helps medical professionals assess risk, tailor the care. Really important stuff.
It's amazing how much info they pack into, a little acronym like that.
Efficiency is key in an emergency. Every second counts.
Right. Now, one thing that stuck with me from the lecture was how normal pregnancy stuff can mask bigger problems.
Oh, absolutely. You mean like nausea, constipation, that sort of thing.
Yeah, exactly. Those are so common they might, hide something serious.
Right. It's like the body's sending signals, but they can get lost in the noise of everything else going on.
Makes sense. And they gave this example, rebound tenderness. Sounded kind of scary.
So you press on the abdomen gently, then let go. If there's pain when you release, that's rebound tenderness.
Okay, so that's definitely not normal.
Not at all. Means there's likely inflammation in there, which is never a good sign during pregnancy.
I'm guessing if anyone's experiencing that, call your doctor, right?
Immediately, yeah. Don't wait.
Now, let's get into some specific complications. First trimester bleeding, always a worry.
Right. It's common, but doesn't always mean something's wrong. Like 20 to 40% of women experience it.
That's a relief. But the lecture did mention some serious causes. Spontaneous abortion, ectopic pregnancy, and what was that last one?
Gestational trophoblastic disease. So basically, 3 very different scenarios, all with bleeding as a symptom.
Right. Miscarriage, that's the most common, right?
Yeah, sadly. Loss before 20 weeks. It's heartbreaking, but often it's nobody's fault. Happens more than people realize.
I imagine a lot of women blame themselves.
It's natural, but important to remember it's usually just biology, unfortunately.
They called ectopic pregnancy a dicking time bomb. Chilling. Why is it so dangerous?
Well, the fertilized egg implants outside the uterus, often in the fallopian tube. As it grows, that tube can rupture.
And that's a big problem, obviously. Internal bleeding, right?
Exactly. Life-threatening, needs immediate surgery.
What are the signs so people know what to watch for?
Sharp, one-sided pain, usually early in pregnancy, along with bleeding. If you have those, don't mess around.
Good advice. Now, this last one, gestational trophoblastic disease, I'd never even heard of it.
It's less common for sure. But basically, cells that would form the placenta, they grow abnormally, can even become malignant.
Wow, okay. So even the placenta can cause issues.
Yep. It's a reminder that pregnancy, even though it's natural, it's also super complex.
We've definitely covered a lot of ground here. I'm feeling more informed, but also whoa, there's a lot to think about.
It's a lot to digest, for sure.
Yeah.
But hey, knowledge is power, right?
Absolutely. And we're going to keep diving in after the break, right? Second and third trimesters, here we go.
Oh yeah, buckle up. It gets even more intense.
Back again. Ew, pregnancy complications, some heavy stuff, huh?
Yeah, we're getting into it.
But important to know, right?
Mhm.
And we're moving on now, second and third trimesters. Bleeding later in pregnancy. The lecture made that sound pretty scary.
It is less common, but when it happens, it tends to be more serious.
Okay, that's good to know. I guess less room for, it being nothing at that point.
Right. Things are further along, so any issues, they have bigger potential impact. The lecture focused on 2 main ones, placenta previa and placental abruption. Big words, but big problems.
Placenta previa, that's where the placenta is blocking the cervix, right?
Yeah. Yep. Partially or completely covering it. And what's tricky is often there's no pain.
Wait, so you could be bleeding but not feel anything.
Exactly. So it's not always obvious something's wrong. The placenta itself can kind of muffle the the signals.
That's wild. So even if it doesn't hurt, bleeding later in pregnancy, that's a huge red flag.
Huge. Call your doctor, go to the hospital, don't wait.
Then there's placental abruption. Sounds even worse, like ripping away from the uterine wall.
Essentially, yeah. And that's a problem because the placenta is the baby's lifeline, oxygen, nutrients, all that.
Right, so if it detaches, the baby's in trouble too.
Exactly. Plus, it can cause major bleeding for the mom.
And sometimes you can't even see the bleeding, they said.
Right. It can be concealed, trapped behind the placenta, so you might not have a lot of visible blood, but the internal bleeding is very dangerous.
Okay, so what should someone watch for if they think this might be happening?
Sudden abdominal pain, especially if it's sharp and doesn't go away. Back pain can be a sign too. And of course, any bleeding at all, even spotting, get it checked out right away.
So in this case, pain might be a better clue than visible bleeding.
Often, yeah, it's your body trying to tell you something's wrong.
There's preeclampsia. I feel like everyone worries about that one. It's more than just high blood pressure, right?
Right, it's a whole system problem. Affects multiple organs. Can damage the kidneys, liver, even the brain.
Serious stuff. And so many risk factors. First pregnancy, family history. It's like,
A lot of pieces to the puzzle, and we don't have all the answers yet. But we do know early detection and management are super important.
so what are the warning signs? What should people be looking out for?
Sudden weight gain, severe headaches that don't respond to, like Tylenol or whatever you're taking. Changes in vision, seeing spots, blurry vision.
Okay, those don't sound good.
Nope. Swelling in the hands and face, too, though some swelling's normal in pregnancy. It's about sudden, dramatic changes.
And then if it gets really bad, it can cause seizures, right? Eclampsia.
That's the most severe form, yeah. Life-threatening for both mom and baby. But thankfully, with good prenatal care, monitoring, it can usually be prevented.
That's a relief. Regular checkups are so important. The lecture also talked about gestational diabetes. I think most people have heard of it, but maybe don't really get what it is.
Think of it like this. Your body's working overtime during pregnancy, right? Supporting the baby. Sometimes the pancreas, which makes insulin, can't keep up with the demand. That's basically gestational diabetes. The body isn't processing sugar as efficiently.
So it's not that the person ate too much sugar or something.
Not necessarily. It's often hormonal, though diet does play a role in managing it once it's diagnosed.
What kind of risks does it pose?
If it's not managed well, it can lead to problems for mom and baby. Higher risk of preeclampsia, C-section. For the baby, they might grow too large, makes delivery harder.
Didn't realize it was that impactful. So even though it usually goes away after pregnancy, still got to take it seriously.
Absolutely. Monitoring, management, all that's key for a healthy pregnancy and delivery.
Wow, we've covered so much today. I'm feeling informed, a little overwhelmed, but definitely more aware of, what can happen.
That's the goal. And remember, most pregnancies are healthy, have happy endings. We're focusing on the what-ifs, so people are prepared, not scared.
Right, exactly. Being proactive, not panicking.
Exactly. Knowledge is power, right?
Now, before we wrap up, I want to shift gears a bit. What can expectant mothers do to, be proactive throughout their pregnancy? What are some practical steps?
Well, the foundation is good prenatal care. Those appointments, they're not just about listening to the heartbeat. It's a chance to talk to your doctor, get any questions answered, get screened for potential problems.
It's like having a partner in the process,
Yeah.
right? Someone to guide you, answer questions.
Exactly. And speaking of questions, don't be afraid to ask them. Your doctor is there to help you. No question is too silly or too small.
I think a lot of people, especially first-time moms, they hesitate to ask, like you're bothering the doctor or something.
I get it, but honestly, it's better to ask than to worry or, misunderstand something.
Definitely. And beyond prenatal care, there's stuff you can do on your own, right? Healthy diet,
Mhm.
exercise, managing stress.
All those things play a role. And of course, knowing the warning signs like we've talked about today and not hesitating to seek medical attention if something feels off.
Trusting your gut, basically.
Yep. If something doesn't feel right, don't ignore it. Better safe than sorry.
Great advice. This has been an amazing deep dive. So much information, but really empowering,
I agree. It's been a pleasure talking through it all with you.
To our listeners, thanks for joining us. We hope this has been helpful, informative, and give you some things to think about as you navigate your own pregnancies.
And before we go, a little food for thought. Considering how dangerous placental abruption can be, what kind of steps do you think hospitals take to, diagnose and treat it quickly? Those minutes can make all the difference.
That's a great question to ponder. Lots to consider there, the behind-the-scenes stuff that goes into ensuring a safe delivery. And that's all the time we have for today's deep dive. Until next time, stay curious, stay informed. We're back, ready to wrap things up. Ooh, a lot of information today. Pregnancy complications, it's a lot to take in.
Yeah, it can be overwhelming, but remember the goal isn't to scare anyone. It's to, arm people with knowledge.
Exactly. So let's talk about what expectant mothers can actually do, to be proactive. What are some practical steps?
Well, the most important thing, honestly, is good prenatal care. Those appointments, they're not just about, hearing the heartbeat. It's about having that open communication with your doctor, getting screened for problems, asking questions.
Right, like building a relationship with your healthcare provider, someone you trust to guide you through the whole process.
Exactly. And speaking of questions, never be afraid to ask them, no matter how small or, silly you think they are.
I think so many people, especially if it's their first pregnancy, they're kind of hesitant to speak up.
Oh, for sure. But your doctor, they've heard it all. And honestly, it's much better to ask and get clarification than to, worry or be confused about something.
Makes sense. So prenatal care is key.
Yeah.
And then outside of those appointments, there's things you can do on your own, right?
Mm.
Healthy diet, exercise, all that.
Absolutely. Taking care of yourself, managing stress, those things make a difference. And of course, knowing the warning signs, like we've talked about today, don't hesitate to get medical attention if something feels off.
Trusting your instincts, basically.
Exactly. Better safe than sorry, always. And, even though we focused on complications, it's important to remember most pregnancies are healthy and result in, beautiful babies. We're just shining a light on the things that can happen so people are aware and prepared.
Right. Informed, not alarmed. That's a good way to put it. This deep dive has been incredible. So much to learn, but I feel much more confident, understanding what to watch for, what questions to ask.
I'm glad to hear that. It's been a pleasure, really, discussing all this with you.
And to our listeners, thank you for joining us on this journey. We hope you found this episode helpful, informative, and, thought-provoking. Pregnancy is a wild ride, but with the right information and a bit of preparation, it can be an amazing experience. And remember, knowledge is power. Stay curious, stay informed, and we'll see you next time on The Deep Dive.
Hey everyone, welcome back. Ready for another deck dive?
Absolutely.
Today we're tackling a pretty intense topic, pregnancy and trauma.
Oh yeah, it's a heavy one.
Our main source material is a medical training lecture focusing on obstetrical traumatic emergencies.
Should be interesting.
So, to kick things off, did you know that 1 in 12 women experience physical trauma while pregnant?
1 in 12. Wow. That's a pretty surprising statistic.
It is, right. Much higher than I would have guessed. So I think our mission today is to really understand, what are the most common types of trauma during pregnancy and what makes pregnancy such a vulnerable time when it comes to these kind of injuries.
Yeah, makes sense.
Where should we start?
Well, the lecture jumps right into breaking down the different types of trauma. And it really emphasizes that this can happen at any point during the pregnancy, with the risks kind of changing as the baby grows.
I see.
But here's a really surprising fact. You ready for this?
Yeah.
Car accidents are the leading cause of death for pregnant women.
Really? Even more so than conditions directly related to the pregnancy itself?
Yep. More than things like preeclampsia or other complications.
Wow. I never would have thought that. I guess it makes sense, though, when you think about the forces involved in a crash.
Exactly.
But are we talking like high-speed collisions here?
Well,
Or can even a minor fender bender be dangerous during pregnancy?
that's what's so scary. The lecture stresses that even seemingly minor impacts, the kind where you might just walk away with a little bruise on a normal day,
Right.
those can have serious consequences during pregnancy.
Oh, wow.
In fact, get this, 60 to 70% of fetal deaths after a trauma
Oh, my gosh.
are linked to those seemingly minor events.
That's a terrifying statistic.
It is.
So what makes those seemingly minor injuries so dangerous? Like, isn't the baby pretty well protected in there?
You'd think so, right?
Right.
But one of the major risks is placental abruption, and that can happen even with relatively minor trauma.
Placental abruption. Can you explain what that is exactly and why it's so dangerous?
Sure. So the placenta, it's this amazing organ that develops during pregnancy, and it basically acts as the lifeline between the mother and the baby. Right?
Okay.
Delivers oxygen, nutrients, removes waste, the whole 9 yards.
Yeah, I know what the placenta is.
But here's the thing. Because of those forces involved in a crash,
Yeah.
even a minor one, the placenta can tear away from the uterine wall,
Oh, wow.
leading to severe bleeding, oxygen deprivation for the baby.
That's scary.
And here's the really frightening part. This can happen within hours of the trauma. even if there are no visible injuries on the outside.
So if you're pregnant and you're in any sort of car accident, even a fender bender, you absolutely have to get checked out by a doctor.
Absolutely, no question about it. Early detection and intervention are key here.
Okay.
And it's not just placental abruption we need to worry about. There's also the risk of uterine rupture.
Uterine rupture, that sounds even more terrifying. What is that and how often does it happen?
Okay, so uterine rupture is basically a tear in the wall of the uterus. Thankfully, it's pretty rare, occurs in about 1 in 1,500 pregnancies.
Okay.
But when it does happen, it's a serious emergency situation, life-threatening for both mother and baby.
Right.
And trauma, especially any kind of blunt force to the abdomen, can definitely increase the risk.
So are there any factors that make someone more susceptible to a uterine rupture during trauma? Is it just bad luck? Or are there things that make it more likely?
Well, the lecture points to previous C-sections or other uterine surgeries as a major risk factor.
Okay.
Basically, any previous incision on the uterus creates a weak point that's more susceptible to tearing under stress.
So if you've had a C-section and you experience any trauma during a later pregnancy, it's even more critical to get checked out right away.
Absolutely. Time is of the essence in these situations. The sooner a uterine rupture is diagnosed, the better the chances of a positive outcome.
Wow. This is all pretty heavy stuff. We've talked about the placenta, we've talked about the uterus, but what about the baby itself?
Well-
Can the baby be directly injured during trauma, even if the placenta stays attached and the uterus doesn't rupture?
Direct fetal injury from blunt trauma is relatively uncommon, less than 1% of cases, but it's still a possibility we need to be aware of.
Right, of course. I imagine, though, that the baby is pretty well protected in there, surrounded by all that amniotic fluid.
You would think.
So when direct fetal injury does happen, what's usually affected?
The lecture highlights that the fetal skull and brain are the most vulnerable, especially in those later stages of pregnancy when the baby's head is engaged in the pelvis.
Oh, I see.
Think about a situation where a pregnant woman experiences a pelvic fracture in an accident.
Right.
That force can be transmitted right to the baby's head.
That's scary. It really makes you appreciate just how fragile life is, especially during those early stages of development.
Definitely.
And it's not just accidental trauma that we have to be concerned about, right?
Right.
The lecture also mentions violence during pregnancy.
Unfortunately, you're right. It's a really tough topic to talk about, but we can't ignore it. And when we talk about violence during pregnancy, we're talking about both blunt force trauma, like we've already discussed, and penetrating trauma from things like stabbings and gunshot wounds.
I imagine penetrating trauma poses a much greater risk to the baby just because of the nature of the injury. But is there a difference in terms of risk between a stab wound versus a gunshot wound?
Yes, definitely. While both are obviously very serious, the lecture explains that gunshot wounds tend to cause more extensive damage because of the shock waves and cavitation that they create.
Cavitation.
Yeah, so essentially, the bullet's impact doesn't just damage the tissue it directly hits. It also creates this temporary cavity that expands outward, causing additional damage to surrounding tissues and organs.
That's horrifying. So what are the chances of a baby surviving a gunshot wound to the mother's abdomen?
The statistics are pretty grim. The lecture states that 70% of gunshot wounds to the abdomen will result in fetal injury. And of those injuries, 40 to 65% of the fetuses die.
It's heartbreaking to think about the impact of violence on these innocent lives, and it really highlights the importance of addressing domestic violence and providing support to pregnant women who are in abusive situations. But let's shift gears a bit and talk about how first responders approach these traumatic events.
Oh, what?
What does the lecture say about, paramedic response and triage?
Well, the lecture emphasizes that the mother's well-being always comes first. Paramedics will follow the ABCs of trauma care, just like they would with any other patient, but they have to consider the baby as well. It's a delicate balancing act.
So how do they factor the baby's well-being into their assessment and their treatment decisions?
Right.
I imagine it's not always easy to tell how the baby is doing, especially in those first few minutes after a traumatic event.
It's not always obvious, you're right. One of the first things paramedics will do is try to estimate the baby's gestational age,
Okay.
which helps them decide where to transport the mother to a trauma center versus a maternity facility. So they use a measurement called fundal height, which is basically the distance from the pubic bone to the top of the uterus.
So the bigger the belly, the further along the pregnancy.
Exactly. And after 16 weeks, the fundal height in centimeters usually corresponds pretty closely to the number of weeks of gestation.
Okay.
So this helps paramedics determine if the baby is viable, meaning it has a chance of survival outside the womb,
Right.
which really influences their transport decisions.
So if the baby is viable and the mother's injuries aren't immediately life-threatening, they might go to a maternity facility where they have, specialists who can care for both the mother and the baby.
Exactly. But if the mother has very serious injuries, or if the baby isn't yet viable, then it's straight to the nearest trauma center or emergency department.
It sounds like a lot of quick thinking and decision-making goes into those first few minutes after a traumatic event.
It definitely does. And the lecture also highlights specific guidelines for transport based on gestational age and the severity of the mother's injuries. For example, if a pregnant woman is 20 weeks or more along and the transport time to a designated trauma center is under 30 minutes, they'll often be taken there, even if they appear stable.
Okay.
It's all about erring on the side of caution.
This has been a really eye-opening look into the often hidden world of pregnancy and trauma.
Yeah.
It's clear that this is a very complex issue with serious implications for both mothers and their babies.
It is. And, beyond just the immediate medical concerns, it's really important to remember the emotional and psychological toll that trauma can take on a pregnant woman and her family.
Absolutely. And there's still so much more to explore.
There is.
In our next segment, we'll continue our deep dive into this medical training lecture, going into more detail about the specific challenges of managing trauma during different stages of pregnancy and the long-term consequences for both mothers and their babies.
Looking forward to it.
So we've covered a lot of ground already in terms of, the types of trauma that can happen during pregnancy and those immediate risks to both the mother and the baby.
Yeah, we've talked about it a lot.
But the lecture doesn't stop there.
Right.
It also goes into detail about how the management of that trauma, how that can change depending on how far along the pregnancy is.
Makes sense.
Does that make sense?
It does, yeah. I mean, think about it. The uterus and the baby, they're constantly growing and changing throughout the pregnancy. So the risks and the considerations, those would naturally be different in the first trimester compared to, say, the third trimester.
Right, totally. So let's break it down by trimester then, starting with those early weeks.
Okay.
I'm guessing that, the first trimester is when the baby is most protected, just tucked away safely in the pelvis.
Well, that's partially true. I mean, in the first trimester, the uterus is still relatively small, and it is well protected within that bony pelvis. So the risk of direct injury to the fetus from blunt trauma, that is actually lower. However, that doesn't mean that trauma is harmless during this stage.
So what are the main concerns then in the first trimester, even if direct fetal injury is less likely?
Well, remember our discussion about placental abruption. That can occur at any stage of pregnancy. And in that first trimester, it can lead to miscarriage or other serious complications.
So even a seemingly minor car accident or a fall, those could have really devastating consequences in those early weeks.
Exactly.
Wow.
And as the pregnancy progresses, the uterus obviously grows larger and moves higher into the abdomen, becoming more vulnerable to injury. So by the third trimester, both the risk of placental abruption and direct fetal injury, those increase significantly.
So the baby becomes more vulnerable as the pregnancy progresses, almost like a ticking clock.
That's a good analogy. And that's why seeking immediate medical attention after any trauma, that is so important regardless of how far along you are in the pregnancy. Time is truly of the essence in these situations.
You keep mentioning time, and the lecture actually talks about this golden hour in trauma care. Can you explain what that is and why it's so crucial for pregnant patients?
Sure. So the golden hour, it refers to that first hour after a traumatic injury, that critical window when medical intervention is most likely to be life-saving. And for a pregnant woman, it's doubly important because we're essentially treating two patients.
Right, the mother and the baby.
Exactly. So any delays in treatment could have serious consequences for both.
That makes sense. And the impact of that trauma can extend far beyond those immediate risks, right?
Right.
The lecture goes on to discuss the long-term consequences that trauma can have for both the mother and the child, even years down the line.
That's right.
Really, we're talking about potential complications that might not even show up until years after the injury.
It's true. So for the mother, trauma during pregnancy can increase the risk of things like preterm labor, premature rupture of the membranes, postpartum hemorrhage. And for the baby, there's an increased risk of developmental delays, cerebral palsy, and other long-term health issues.
Wow. That's a sobering thought. It really highlights the fact that trauma is not something to be taken lightly, especially during pregnancy.
It's not. And it really underscores the importance of providing comprehensive care to these pregnant trauma patients. So it's not just addressing those immediate physical injuries, but also considering the potential for these long-term complications.
So it's not just about patching them up and sending them on their way. It's about taking a more holistic approach, considering both the physical and the emotional well-being of both the mother and the baby.
Exactly.
Okay.
And that brings us to another really important aspect of care that the lecture emphasizes, and that is the psychological trauma that often accompanies these physical injuries.
Right. We haven't really talked about that too much yet. How does trauma affect a pregnant woman psychologically? I imagine it must be incredibly stressful to, experience a serious injury while you're carrying a child.
Think about it. You're already dealing with all the normal anxieties and the hormonal fluctuations that come with pregnancy. And then you layer a traumatic event on top of that. The fear, the worry, it's amplified because you're not just concerned about your own safety anymore, but also the safety of your unborn child.
It must be terrifying.
It can be. And that acute stress can have a significant impact on both the mother's mental health and really the course of her pregnancy.
So are we talking about, conditions like post-traumatic stress disorder, anxiety, depression?
Exactly. These are all, unfortunately, very real possibilities for pregnant trauma survivors, and they can have ripple effects, affecting not only the mother's well-being, but also her ability to bond with her baby and provide adequate care after the birth.
It sounds like mental health support is absolutely crucial as part of that overall care plan for pregnant trauma patients.
It is. Addressing the psychological impact of the trauma, that's just as important as treating those physical injuries. And that might involve therapy, support groups, or even medication, depending on the severity of the symptoms.
It's about treating the whole person, not just the physical wounds.
Well said. And the lecture also brings up a point that's often overlooked, and that's the importance of involving the father or partner in that healing process.
Right, because they're going through this traumatic experience together, even though their experiences might be different.
Exactly. Partners often experience fear, anxiety, even guilt in these situations. They might feel helpless, unsure of how to support their pregnant partner.
So it's important to acknowledge their emotions and provide them with resources and support as well.
Absolutely.
Mm-hmm.
Including the partner in the care plan. It strengthens the family unit as a whole, and it creates a more supportive environment for both the mother and the baby. It's a reminder that trauma affects everyone in the family.
That's a really good point. Okay, so we've talked a lot about the risks and the challenges associated with trauma during pregnancy, but the lecture also spent some time discussing prevention, which is obviously really important.
It is.
So while we can't prevent every accident or every traumatic event, are there things we can do to at least minimize those risks and maybe reduce the severity of the injuries if they do occur?
Absolutely. And the lecture highlights some key preventive measures. So, for example, when it comes to car accidents, wearing a seatbelt correctly is essential. And for pregnant women, there's a specific way to wear that seatbelt to really maximize protection for both themselves and the baby.
Okay, I'm all ears. What's the proper way to wear a seatbelt when you're pregnant?
The lap belt should be positioned low across the hips, below the belly, and the shoulder belt should go across the chest, between the breasts, and over the shoulder. And it's really important to avoid placing that shoulder belt across the belly because that can increase the risk of injury to the uterus and the placenta in a crash.
That's a really simple tip, but it could make a huge difference. What other preventative measures are important?
Well, beyond seatbelt safety, it's crucial to avoid risky behaviors, such as driving under the influence of alcohol or drugs, speeding, texting while driving, all those common sense precautions. But they're even more important when you're carrying a precious passenger.
Right, and it's not just about preventing car accidents. What about falls, which we know are another common cause of trauma during pregnancy?
Falls are a big concern, especially as the pregnancy progresses and balance becomes more challenging. So the lecture recommends being extra mindful of your surroundings, wearing supportive footwear, avoiding slippery surfaces, using handrails whenever possible, and, don't hesitate to ask for help with tasks that require reaching or climbing.
It's all about being proactive and creating a safe environment for yourself and your baby.
Exactly. And then when it comes to violence during pregnancy, prevention takes on a whole other dimension. It's about raising awareness, providing support to women in abusive relationships, and advocating for policies that protect their safety and well-being. It's a societal issue that really requires a multifaceted approach.
It's about creating a world where pregnancy is a time of joy and anticipation, not fear and violence.
Well said. And I think that's a perfect segue into our final segment, where we'll delve into the more nuanced aspects of trauma care for these pregnant patients, including the use of imaging, fetal monitoring, and the really complex decision-making process that medical professionals often face in these challenging situations.
Okay, so we're back, ready to wrap up our deep dive into pregnancy and trauma.
Time to get into the nitty-gritty.
This medical training lecture has been packed with information.
Yeah, it really has.
But I feel like we're finally getting to, the more intricate aspects of care.
Right.
I'm especially interested in how doctors use imaging studies, like x-rays and things, in pregnant trauma patients. Because it seems like there's this tricky balance between, getting the information you need and minimizing any potential risk to the baby from radiation exposure.
It's definitely a concern.
Right.
The lecture emphasizes that while radiation is a concern, the benefits of necessary imaging, they far outweigh the risks in these trauma situations.
Right.
So if an X-ray or a CT scan is needed to diagnose a potentially life-threatening injury, it should be done without delay.
Okay.
And the amount of radiation from these tests is very low, so it's unlikely to cause any harm to the developing baby.
That makes sense. It's a risk versus benefit calculation, right?
Exactly.
And in these situations, getting a clear picture of what's going on internally is absolutely critical.
Absolutely. And whenever possible, doctors will opt for imaging methods that don't involve radiation at all.
Right.
The lecture specifically mentions ultrasound as the preferred imaging modality for pregnant trauma patients
Okay.
because it's safe, it's effective, and you can assess both the mother and the baby.
So they can use ultrasound to check for things like placental abruption, internal bleeding, and even assess how the baby is doing.
All of that, yeah.
Wow, ultrasound is pretty amazing.
It is. It really is. It gives you this window into what's happening inside without, exposing the baby to radiation.
You mentioned assessing how the baby is doing, and the lecture also talks about fetal monitoring.
Mm-hmm.
Can you explain what that involves and why it's so important?
Sure. Fetal monitoring is basically continuously tracking the baby's heart rate.
Okay.
So like having this extra set of eyes on the baby's well-being, making sure they're not showing any signs of distress.
So even if the mother seems stable after the trauma, the baby might still be in trouble.
Exactly. Fetal distress can happen even if the mother doesn't have any, obvious injuries. And that's why that continuous monitoring is so crucial. It can alert the medical professionals to problems very early on, allowing them to intervene quickly if necessary.
So they don't just monitor the baby for a few minutes and then call it a day.
Oh, no. The lecture recommends continuing that fetal monitoring for at least 4 hours after the traumatic event, even if everything looks normal initially.
Wow.
It gives doctors a chance to really catch any delayed complications that might arise.
It's all about being as cautious as possible when it comes to the health of both the mother and baby, right?
Exactly. And that brings us to, I think, one of the most challenging aspects of trauma care during pregnancy. The ethical considerations that come into play when you're potentially dealing with the loss of 2 lives.
I can't even imagine.
It gets really complex, really difficult.
Right.
What are some of those ethical dilemmas that the lecture highlights?
Yeah, I'm curious about that.
Well, one of the most heart-wrenching scenarios is when the mother's life is in imminent danger, and the only way to save her is to deliver the baby prematurely, even though that might mean that the baby won't survive.
That must be just an impossible decision for everyone involved.
It is, and the lecture makes it clear that there are no easy answers in these situations.
Right.
It stresses the importance of open communication between the medical team, the patient, and her family, so that they can make the best possible decision together, taking into account the unique circumstances of each case.
It's about respecting the patient's wishes as much as possible, while also doing everything you can to preserve life.
Absolutely. And sometimes these situations are so complex that an ethics committee is brought in to help navigate these really, really difficult choices.
Wow. It's a reminder that medicine isn't just about science. It's also about compassion and empathy and understanding the profound weight of these, life or death decisions.
Well said. And I think that's a powerful takeaway from this entire deep dive. Trauma during pregnancy, it's a very complex issue, but with knowledge, awareness, and a compassionate approach, we can work to improve outcomes for both mothers and their babies.
As we've been talking, I keep thinking back to that statistic we started with. 1 in 12 women experience physical trauma during pregnancy. It's just a sobering reminder that this isn't some rare or obscure issue. This affects countless families every single year. It does. And I think that's what makes this deep dive so valuable.
I agree.
It's, shining a light on an often overlooked problem and hopefully empowered our listeners with, knowledge and resources.
Knowledge is power, right?
Exactly. And speaking of empowering, we're going to switch gears and tackle a whole new topic in our next episode.
Sounds good. I'm looking forward to it.
As always, it's been a privilege to, share this deep dive with you and with our listeners.
Likewise.
And remember, listeners, if you have any burning questions or, any fascinating topics you'd like us to explore, send them our way. We're always on the lookout for new adventures and knowledge. Until next time, stay curious, stay informed, and most importantly, stay safe. Welcome to our deep dive, everybody. This time, we're going to be taking a look at V4R and 15-lead ECGs. And those of you out there in the medical world, we're talking about going beyond the standard 12-lead ECG, trying to find some hidden heart problems that might be going on during a heart attack. And we've got some really interesting research articles and medical directives today that really highlight, I think, the importance of these ECGs and how they can even impact decisions about critical medications like nitroglycerin.
Yeah, you hit the nail on the head when you say, hidden heart problems.
Yeah.
I think what's really important to emphasize here is that, a standard 12-lead might miss some important information about the right ventricle and the back wall of the left ventricle in areas that can definitely be affected during a heart attack.
Yeah, it's almost like we need a wider lens to really capture what's going on.
Exactly. And that's where these, the V4R, the 15-lead ECG come in. They give us those extra views. They help us to detect issues that might otherwise go, unnoticed.
Okay, so let's start with this V4R. Our sources describe it as a simple but powerful tool. So can you just break it down for us? What exactly are we talking about?
Yeah. Think of it this way. It's like adding a special lens to see the right ventricle more clearly. And what we're basically doing is moving the V4 electrode, from its usual spot on the left side of the chest to the same position, but on the right side.
Okay. Now, I'm seeing in the research here that this V4R lead is crucial when there are signs of what's called an inferior STEMI, which is elevation in leads 2, 3, and AVF on a 12-lead ECG.
Yeah, you got it. And the key here is to get this V4R reading before even thinking about giving nitroglycerin. Because here's the thing. Nitro can be a lifesaver in many cases, but it can actually be really harmful if someone is having a right ventricular myocardial infarction, or RVMI.
Hold on. Harmful. I mean, nitro is usually given to help during a heart attack. Explain that to me. Why would it be dangerous in this situation?
Yeah, so nitro works by widening the blood vessels, and that can reduce the workload on the heart. But the right ventricle, it relies on a good amount of blood volume, what we call preload, to function properly, and nitro reduces that preload. And so if the right ventricle is already weakened by a heart attack, using nitro could cause a dangerous drop in blood pressure.
Oh, okay. That makes sense. So essentially, the V4R is helping us determine if it's safe to use that nitro by giving us a better look at the right ventricle. So if we're looking at this V4R, what should healthcare providers be looking for to suggest that that RVMI? What are the signs?
Yeah, so an elevation of just 1 millimeter or more in that V4R lead can be a red flag that might make us shift our treatment strategy. It's pretty remarkable how, such a small change can have some pretty significant implications.
Yeah, for sure. And speaking of red flags, are there any signs and symptoms that should make a healthcare provider think, maybe we should check for this right ventricular infarction?
Yeah, there's this classic triad of symptoms. You've got jugular vein distension, which is basically bulging neck veins, low blood pressure, especially if it gets worse after you give nitro, and clear lung sounds. If these signs are present, along with that inferior STEMI, that should be a huge red flag. Healthcare providers should be getting a V4R ECG immediately.
Wow, this is really eye-opening. I mean, it seems like V4R is all about making those critical decisions about nitro. But now we also have the 15-lead ECG. So is that just kind of an extension of the V4R, or is it a different thing altogether?
Yeah, the 15 lead is a little bit broader. It includes that V4R lead, but then we also add 2 more leads on the patient's back, leads V8 and V9, which give us a direct look at the posterior wall of the left ventricle, another area a standard 12 lead might miss.
Okay, so now we're getting eyes on the back of the heart. So when would we use this 15 lead?
It's definitely the go-to when someone has an inferior STEMI to check for that posterior wall involvement.
Yeah.
And it's also useful if there's what we call reciprocal changes on the 12-lead ECG, specifically ST depression in leads V1, V2, and V3, which can be a sign of a posterior MI.
So it sounds like this 15-lead ECG is our detective, right? We're trying to piece together the whole picture of this heart attack, especially when that initial 12-lead kind of raises some questions.
Yeah, and that 15 lead, it gives you more confidence in deciding, is nitro safe here? If the posterior wall is involved, especially in isolation, nitro may be fine to give, but the 15 lead helps us make that determination.
Okay, I'm starting to see how this all fits together. So now that we know kind of what these extra leads do, what about the practical side of it? We know V4R is placed on the right side of the chest, but how do we get V8 and V9 for that 15 lead? Where do those go?
So picture this. V8 is placed on the back, aligned with where V4R is on the front. On the fifth intercostal space, which is basically the space between the fifth and sixth ribs, along what we call the mid-scapular line. And then V9 sits between V8 and the spine.
So we're basically mirroring what we did on the front, just on the back of the patient. Okay, that makes sense.
And there's a really important point that our research highlights here. The interpretation of both the V4R and the posterior leads V8 and V9 needs to be done manually by, a healthcare professional, because the machine software can't always be trusted to get it right.
Wait a minute, seriously. I mean, I would assume that those machines would just, figure that out.
It's a good reminder that even with all of our fancy technology, the human eye is still really crucial in interpreting these ECGs. And for a posterior MI, we consider an elevation of 1 millimeter or more in both V8 and V9 to be significant.
So even small changes in those posterior leads could be super important. This really shows just how important it is to have, real expertise involved in actually reading these ECGs, not just relying on the machine.
Absolutely. And that's one of the reasons why, this deep dive is so valuable, because the more you understand about these tests, the better you'll be able to, advocate for yourself or a loved one in a critical situation.
I think, yeah, this has been really insightful so far. We've talked about what these tests are, why they're important, how we do them. I feel like I'm already much more empowered to understand these things now.
Good. And we're just getting started. In the next part, we're going to get into some real-world scenarios, see how these ECGs actually play out when we're dealing with real patients.
All right, sounds good. Can't wait. All right, so we've laid the groundwork. We know about V4R. We know about 15-lead ECGs. Now, let's kind of put it into practice. Imagine you're a healthcare provider, you're in the ER, you've got a patient coming in with classic heart attack symptoms, and you've got that inferior STEMI on their 12-lead ECG. What happens next?
Well, before we jump to any conclusions, the most important thing is to get that V4R reading right. Remember, we're looking for any elevation that might suggest a right ventricular infarction, and that's going to totally change how we approach treatment.
Okay, so let's say that V4R does show an elevation. Nitro's off the table, right? What do we do then?
Exactly, you got it. Nitro would be a really bad idea in that situation. Instead of trying to reduce preload with nitro, we might actually need to give fluids to help support that right ventricle. Totally different approach based on that one extra lead.
Wow, yeah. That really shows you how much of a difference that V4R can make. But what if the V4R is normal, but on that 12-lead ECG, we're seeing those ST depressions, in leads V1 to V3 that hint at a possible posterior MI.
Well, that's when we bring in the 15-lead ECG, right? Remember those leads V8 and V9 on the back? They give us that clear view of whether that posterior wall is involved.
And if those posterior leads show, a significant elevation, then we're dealing with, a bigger heart attack, right?
Yeah.
More complex.
Exactly. And that might mean we need to be more aggressive with our treatment compared to a heart attack that's only affecting the inferior wall. So again, it all comes down to getting the right information to make the best decisions.
It's like we're putting together a puzzle and we need all the pieces, to see the whole picture. Now, I'm curious, how is this all reflected in medical guidelines? Are these insights actually making their way into the official recommendations and directives?
Well, yeah, it's interesting. Medical directors are actually starting to catch up with the research. More and more of them are explicitly saying that we have to get a V4R before giving nitro to someone with a suspected inferior STEMI.
That's a big deal. I mean, it sounds like a huge step forward for, patient safety.
Absolutely. And it really drives home the point that V4R isn't just a nice to have. It's a must do in these situations.
Okay, what about the 15 lead? Are there specific directives out there about when we should be using that?
It's not as widespread as V4R, but a lot of directives recommend it in cases of suspected inferior STEMI, or when, we see those reciprocal changes on the 12 lead that might suggest a posterior MI.
So it's becoming more and more recognized as a valuable tool, especially in those more complex cases.
Right. And there's another point that some directives emphasize. They They caution against relying solely on the computer interpretation of these ECGs,
Yeah.
They really stress that we need a trained healthcare professional to look at it manually.
Right. So again, that human element, that expertise, it's still so crucial.
Absolutely.
Oh.
Because technology is great, but it can't replace a trained eye and that critical thinking.
So we've talked about all the good things about V4R and 15-lead ECGs, how they help us. But I gotta ask, are there any limitations? I mean, do they always give us a clear answer?
That's a really good question. And, like any test, they're not perfect. Sometimes the findings can be a bit unclear, We have to look at everything, not just the ECG.
Yeah.
We've got to consider the patient's symptoms, their overall clinical picture, and then put it all together.
So it's more than just looking at the lines on the paper. You really got to look at the whole patient.
Exactly.
Mhm.
Like a patient might have some subtle changes on the ECG, and maybe it doesn't quite meet those strict criteria for a STEMI,
Yeah.
But their symptoms and everything else is screaming heart attack.
Okay. So that's when you really need that experience and judgment to make the right call.
You got it. Sometimes we have to make decisions about more tests or treatment based on everything, not just the ECG alone.
It's fascinating. We're moving away from just rigid rules and looking more at the whole picture, understanding how these ECGs fit into the bigger puzzle. But okay, what about the practical stuff, like lead placement, those textbook positions? I mean, they're not always possible in real life, are they?
No, they're not. Sometimes you've got things that make it tricky, like, we call it body habitus, which basically means body shape and size. Or sometimes a patient has a condition that makes it difficult to put the leads exactly where they need to be.
So you got to adapt, basically. Think on your feet.
Exactly.
Yeah.
That's why it's so important for the healthcare provider and the ECG technician to communicate. Make sure those leads are as accurate as possible so we get reliable results.
It's all about teamwork, right? Everyone working together. Okay, I've got one more question. I saw something in the research about false positives and false negatives. What does that mean exactly?
Right. Well, it's a good reminder that no test is perfect, right? A false positive means the ECG might look abnormal, like it's a heart attack, but it's not. Maybe it's something else entirely. There's a normal variation called benign early repolarization that can sometimes look like a STEMI on the ECG.
So it's kind of like a false alarm. It could lead to doing things that aren't necessary.
Yep, exactly. And then you got the opposite. False negatives. That means the ECG looks normal, but the person is actually having a heart attack. And that can happen because of, maybe the leads weren't placed right, or there's a problem with the ECG machine, or maybe the person has some other heart condition that's masking the changes we usually see.
Wow, that's a bit scary. I guess it really shows how important it is to consider all the information, not just the ECG.
Couldn't said it better myself. We use these ECGs. They're great tools, but they're not the only thing we should be looking at.
So it's like a balance, right? You've got the science of the ECG, but you also need the art of medicine, using your knowledge and experience to take care of each patient.
That's a really good way to put it. We use these tests, but we have to be smart about it, recognize their strengths and weaknesses, and make good decisions.
This has been really amazing. We've gone from the theory to the practical, We've seen how V4R and 15-lead ECGs are used in the real world, and we've talked about some of the challenges too. What else have we got?
Well, for our final part, let's bring it home. Let's talk about what this all means for you, the listener. Because at the end of the day, knowledge is power, especially when it comes to your own health.
Okay, sounds good. Let's keep going. So we've learned a ton about V4R and 15-lead ECGs. But now, what does all this mean for, the average person? What can they take away from this?
Well, this is where it gets really interesting. Because, we always say knowledge is power, right? And when it comes to your health, that's definitely true.
So imagine this. You're at home, and you start having those classic heart attack symptoms, chest pain, pressure, maybe it's going down your arm, you're short of breath, the whole 9 yards. You call 911, the paramedics show up, they're going to put you on a 12-lead ECG,
But now you've listened to this deep dive. You remember that a standard 12-lead ECG, it might miss important stuff, right? Like what's happening with the right ventricle at the back of the heart.
And you can speak up. You can actually say to the paramedics, hey, did you consider doing a V4R? Maybe a 15-lead ECG.
Think about that. Just by knowing this information, you could actually change how you're treated and maybe even have a better outcome.
It's about, taking control, right? Being involved in your own healthcare.
Absolutely. It's about being informed, knowing what questions to ask. Of course, we always say this deep dive is just for information. It's not medical advice, right?
Yeah, always talk to your doctor. But the point is, you can start a conversation. You can understand what's going on and feel more confident about speaking up for yourself. So, as we wrap up, I want to leave you with this. What other questions do you have now about heart attacks?
Yeah, maybe you're thinking about new technology, new types of ECGs,
Mm-hmm.
or what about other tests like those cardiac biomarkers? What role do those play in diagnosing a heart attack?
Or maybe you're thinking, how can I prevent this from happening in the first place?
Hmm.
What can I do to lower my risk of heart disease?
Whatever it is, keep asking those questions. Talk to your doctor. Do some research. Like we said, knowledge is power. And when it comes to your heart, that power could save your life.
I think that's a great place to end it. Thanks for joining us for this deep dive into V4R and 15-lead ECGs.
Yeah, it's been fun.
We hope you feel a little bit more empowered now to take care of your heart. Until next time, stay curious and keep diving deep.
All right, so are you ready to go deep on something kind of fascinating with me?
Always. What are we diving into today?
Today, it is all about tracheostomies.
Tracheostomies. I like it.
Yeah, we are going to uncover some pretty surprising stuff today.
Okay, I am ready.
So first things first, can you picture like the anatomy of your throat?
I am picturing it right now. Yeah, I can see it.
So walk me through it.
Okay, well, we have got the nose and mouth, obviously.
Of course.
And then right behind that is the larynx.
The larynx.
Or the voice box. And then the trachea.
Okay.
That is the tube that carries the air down to the lungs.
So essentially a tracheostomy kind of creates like a shortcut.
Exactly. It bypasses all of that and gets the air straight to your lungs.
Okay, so what would be some reasons that someone might need that shortcut?
Well, imagine that something is blocking the highway.
Oh.
That is where a tracheostomy comes in. So we are talking obstructions like tumors, injuries, even foreign objects.
Foreign objects. Wow.
Things getting stuck, you name it.
Yeah. Okay. I can see how that could be a problem.
It definitely is. But that's not all. There are certain medical conditions that can also affect breathing.
Okay.
So we are talking things like COPD, spinal cord injuries, neuromuscular diseases.
Yeah.
And these can weaken the muscles that you need to breathe. So making a tracheostomy a real lifesaver in some cases.
So it's almost like a backup system.
Exactly. And sometimes people need to be on a ventilator for a long time.
Yeah.
And a tracheostomy can make that easier and safer.
Mm-hmm.
And it's a lot more comfortable for long-term use.
Now, I have heard of this thing called a cricothyrotomy. Is that related?
Good catch. So a cricothyrotomy is similar
Okay.
in that it creates an airway, but it's an emergency procedure.
Gotcha.
Usually done when someone can't breathe at all.
Okay.
And there is no time to perform a tracheostomy.
Like in the medical shows when they just take the scalpel and
Exactly.
make an incision in the neck.
Exactly. It's a last resort, but a crucial one in some situations. But we are focusing on tracheostomies, which are usually planned surgical procedures.
Well, and get this. I was reading that there are actually different types of tracheostomies.
Right.
It's not just one size fits all,
Exactly.
kind of thing.
So you have emergency tracheostomies,
Okay.
which are when someone's airway is like immediately threatened. But then there are elective or what we call routine tracheostomies
Okay.
that are planned in advance.
So what would be an example of that? A planned tracheostomy.
So let's say someone has a tumor blocking their airway.
Okay.
They might have a tracheostomy done while they're undergoing treatment.
Which is a temporary.
Exactly. A temporary measure to help them breathe during that time. And then there are permanent tracheostomies
Gotcha.
for people who can't breathe on their own long term.
Wow, this is so much more intricate than I imagined.
Right. It's fascinating. And some of the tubes even have these little windows.
Little windows.
Little windows, yeah. They are called fenestrations.
Fenestrations. Can you like peek inside?
Not quite.
Okay.
So fenestrations allow air to flow up to the vocal cords so people can talk even with a tracheostomy.
Wait. So you can still talk with this tube in your throat?
It is. It takes a little practice and therapy.
Right.
But it just shows how adaptable we are as humans.
Mm.
And speaking of adaptations,
Yeah.
the audio source that we were listening to even mentioned that some people prefer those old school metal tubes.
Metal tubes. Like permanently?
It's true. They are less common now, but they are still chosen by some longtime users.
Wow.
It might be about familiarity
Right.
and comfort after having one for so long.
Yeah, for sure.
It's like those comfy old shoes you just can't get rid of.
So I can definitely see how you would get attached to something that is literally helping you breathe.
Mm.
But now I am really curious. What is it actually like to live with a tracheostomy?
Well, that's where things get really interesting. Imagine not being able to just clear your throat or cough the way you normally do.
Right.
And there is this regular suctioning that has to happen to remove mucus from the airway,
Yeah.
which can be a big adjustment.
Yeah.
But as we've seen, humans are incredibly resilient. They find ways to adapt and live full lives even with these challenges.
But how do you talk if you
Yeah.
have to clear your airway all the time? That just seems like such a...
That is where those fenestrative tubes we were talking about come in.
Right.
They can let air flow past the tube and up to the vocal cords,
Okay.
making speech possible.
That is so cool.
It's not always easy, but it shows how much thought goes into designing these tubes to really meet people's needs.
Yeah.
But now I am thinking, what happens if something goes wrong?
Oh, yeah.
Like, what if the tube gets dislodged or something?
That would be scary.
Yeah. So that is where our everyday heroes come in. Paramedics.
So someone with a tracheostomy is having an emergency.
Yes.
What is going through that paramedic's mind when they arrive?
Well, they have a lot to consider, but thankfully there is a helpful mnemonic that they use to quickly assess the situation. DOPES
Dopes. Okay, break down dopes for me.
stands for displacement of the tube, obstruction of the tube, patient issues,
Okay.
like breathing problems, equipment problems, like maybe a faulty ventilator, and stacked breaths,
Okay.
which can be a sign of trouble in someone on a ventilator.
That is a lot to remember under pressure.
It is like a mental checklist
Yep.
to make sure they are covering all the bases. But let's say the worst happens and the tracheostomy tube gets completely dislodged.
Oh, my God.
Their training kicks in, and they work very systematically to manage the situation.
So what would be the first move in a situation like that?
The first thing is to stay calm
Of course.
and assess the situation, check the patient's vitals,
Right.
and especially their oxygen saturation to see how well they are breathing.
Gotcha.
And then they would try to reinsert the tracheostomy tube if possible. But sometimes it's not that simple.
Right.
What if they can't get it back in?
Oh, my goodness. What happens then?
That's when it can get a little hairy. If reinserting the tracheostomy tube is not an option, the paramedic might try to ventilate the patient through their mouth and nose.
Right.
But that's not always effective either.
Why not?
Well, remember those obstructions we talked about earlier?
Yeah.
If the reason for the tracheostomy is something blocking the upper airway,
Oh, right.
like a tumor, then trying to ventilate through the mouth and nose won't work.
Because the air's still blocked.
Exactly. So in those cases, they might need to try a more advanced technique, like intubating the patient.
Intubation.
Yeah.
Like putting a tube down the throat.
Exactly. But with a tracheostomy, it's not as simple as just going through the mouth. They might have to intubate through the stoma,
Oh.
which is the surgical opening in the neck made for the tracheostomy.
Wow, that sounds so difficult.
It is. It requires specific training and a lot of skill,
Yeah.
especially in an emergency setting.
It's amazing to think about all of the things that paramedics have to be prepared for.
It is. They play such a crucial role. And their ability to stay calm and think clearly under pressure is truly remarkable. So we've talked a lot about the medical side of things, but what about the human side of things? What is it actually like to live with a tracheostomy?
Exactly.
And that's a great question and one that we are definitely going to explore further.
Okay.
But for now, let's take a quick break. When we come back, we will delve deeper into the everyday realities and the incredible resilience of people living with tracheostomies.
Okay. Welcome back to our deep dive all about tracheostomies.
I am ready for more.
Me too. And I think where we left off, we were talking about paramedics.
Right.
In those like high pressure situations. But now let's kind of shift gears
Yeah.
and talk about what it's actually like to live with a tracheostomy day to day.
Yeah, definitely a major adjustment. And, the audio source that we were listening to was highlighting some of the daily challenges.
Yeah.
Like needing to suction mucus from the airway regularly.
Yeah, I can't even imagine having to do that.
It's not the most pleasant experience, but it's necessary to keep the airway clear.
Right.
And then there is coughing. You know how satisfying it is to just let out a good cough when you need to?
Oh, yeah, for sure.
Well, with a tracheostomy, it doesn't work the same way.
So how do you cough if you have a tracheostomy?
It's a lot harder to generate enough force to clear the airway effectively.
Oh, wow.
So they might have to use, assistive techniques
Yep.
or devices to help them cough.
So I bet that's frustrating.
Yeah, it is.
Yeah.
It's like one of those things we take for granted
Right.
until it's not an option anymore.
For sure. Are there any other kind of things that people with tracheostomies have to adapt to?
One of the biggest challenges, and this is something that the audio source we were listening to really emphasized,
Yeah.
was the impact on speech.
Right.
We talked about those fenestrated tubes that can help,
Well,
but learning to speak clearly with a tracheostomy takes time and effort.
yeah, it's like relearning to communicate in a way.
It is, and it can be so isolating and emotionally challenging. Imagine trying to, express yourself or tell a joke or just have a casual conversation and your voice isn't cooperating.
That would be so hard.
Yeah.
You know what I mean? Like so hard.
It really is.
Yeah.
And it takes a lot of patience and determination to overcome those hurdles.
I bet. So how do people overcome those hurdles?
Well, thankfully, there are speech therapists who specialize in helping people with tracheostomies regain their voice.
Yeah.
And there are support groups out there
Gotcha.
where people can connect with others who understand what they're going through.
It's like you're finding their people,
Exactly.
who get it.
Yeah, finding your tribe, a community
Right.
of people who get it.
Totally.
And that sense of community can be so empowering. It reminds people that they're not alone in this journey.
For sure. For sure. So it seems like living with a tracheostomy affects, kind of all aspects of life.
It does, but one of the things that really struck me when I was listening to the audio source is the resilience of the human spirit. People find ways to adapt, to overcome, to live full and meaningful lives, even in the face of all these challenges.
It really makes you realize that, what might seem like a limitation can actually be a source of strength.
Absolutely. And that brings us to another fascinating aspect of tracheostomies,
Okay.
the ethical considerations.
Yeah, what do you mean?
Well, think about situations where someone needs a tracheostomy long term,
Right.
but they're unable to communicate their wishes.
Yeah, it's tough.
Or cases where a tracheostomy might prolong life, but the quality of life is significantly impacted.
Right.
These are complex decisions with no easy answers.
Well, for sure. So it's really thinking about the bigger picture, I guess.
It is. It's the human impact,
Yeah.
the ethics of it all. And it highlights the importance of open communication between healthcare professionals and families and the patients themselves.
It's about respecting individual values and making decisions that are, truly in the patient's best interests. It's about recognizing that every case is unique and there's no, one-size-fits-all approach.
I couldn't have said it better myself. It's about approaching these situations with compassion and empathy and a deep understanding of the complexities involved.
Totally. So, we have explored the mechanics and the challenges and the triumphs. And, it feels like we've really journeyed through the world of tracheostomies.
We have.
But like any deep dive, I'm sure there's still more layers to uncover.
There always are. But for now, let's take a moment to reflect on what we've learned. What stands out to you the most from our conversation?
Honestly, it is the resilience of the human spirit to face those challenges head on
Right.
and find ways to adapt and thrive.
I agree. It's incredibly inspiring.
Yeah.
And it reminds us that even in the face of adversity, there is always hope.
Yeah.
Always a reason to keep fighting, keep learning, keep growing.
For sure. So what's next on our tracheostomy adventure?
Well, we have talked about the importance of support networks for people with tracheostomies.
Right.
But I think it's time to kind of delve a little deeper into that. What kind of resources are out there to help them adapt and connect and thrive?
That's a great question, and one that we'll explore when we come back after a quick break.
Yeah.
All right, so we're back and ready to kind of wrap up our deep dive into the world of tracheostomies.
Sounds good.
We've covered a lot of ground, from the technical stuff to the emotional and the ethical considerations.
Right.
But before we go, there's one more piece of the puzzle that I really want to explore,
Okay.
and that is support networks.
Yeah, it's so easy to get caught up in the medical aspects of things,
Right.
but we can't forget about the human side.
Yeah.
Living with a tracheostomy can be isolating, and having a strong support system is crucial.
It's like anything else in life, right?
Mhm.
When you are going through something difficult or you're facing a challenge, having people who understand and can offer support just makes such a difference.
Exactly. And the audio source we were listening to even touched on this. It talked about support groups, but it goes way beyond that.
Right.
We're talking family, friends, healthcare professionals, even online communities.
Wow.
Finding those connections that can really help people adapt and navigate those challenges and thrive.
Yeah, for sure. So what kind of support do these networks actually provide?
Well, it can be a lot of things.
Right.
It could be practical advice and tips for managing daily life with a tracheostomy,
Right.
to emotional support, and just a sense of belonging.
Yeah.
It's about sharing experiences, learning from each other, and just knowing that you're not alone in this journey.
It's got to be so reassuring to connect with people who really understand what you're going through.
Totally. It's like having a shared language,
Yeah, for sure.
a common ground. And it's not just about the people with tracheostomies.
Right.
Their families need support too.
Of course.
Caregivers. It can be a lot to handle emotionally and practically.
Takes a village.
It does. And one of the things I think is really cool about these support networks is they empower people to advocate for themselves, to educate others, and to break down the stigma surrounding tracheostomies.
Stigma.
Yeah. Sadly, there can be a lot of misconceptions and even fear around tracheostomies. People might stare or make assumptions or just completely avoid interacting with someone who has one.
I never really thought about that. Makes sense, though.
Yeah. So that's why these support networks are so vital. They not only provide that safe space for people to connect and share, but they also help to raise awareness and educate the wider community.
It's like changing perceptions one conversation at a time, right?
Exactly. It's about showing the world that people with tracheostomies are just like everyone else. They have lives and dreams and passions.
Exactly. So as we wrap up this deep dive,
Yeah.
what's the one thing you want our listeners to remember?
I think it's that tracheostomies are more than just medical procedures.
Yeah.
They represent a whole world of experiences and challenges and triumphs, and they are a reminder of the incredible adaptability of the human body and spirit,
Yeah.
and the importance of community and support and understanding.
It's a reminder that even something that seems unfamiliar or even scary can be a source of strength and connection.
Couldn't have said it better myself. Keep learning, keep exploring, and keep diving deep into the world around us.
And that is a wrap for this deep dive on tracheostomies. Thanks for joining us.